Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Welcome to the second Well Leadership workshop. My name is Rola Shaheen. Most of you know me. I'm the co-founder for the Women's Imaging and Leadership Lab. I'm also a radiologist with focus on breast imaging. I'm very happy and proud to be here in person. And I'd like to say that this is actually a hybrid workshop where we have on-site audience, on-site speakers that I would like to welcome, and moderators. And we do have as well virtual speakers and virtual attendees from global background as well. So again, I'm so excited, and I would like to give you a quick overview and some housekeeping things. We have 3 sessions. After the second session, we're going to have a 10 minutes coffee break. Probably you cannot see it accounted for in the program, but definitely we have to give you a biological break, and we're going to have some coffee and some snacks. The other thing is, and especially for the virtual audience, please feel free to send your questions and comments. My colleague will be checking this so that we can ask that. We're going to ask the questions at the panel discussion, which is the last 10 minutes after each session. And as you can see on the program, we do have different moderators. I would like to introduce my colleague and friend, Dr. Sawsan A. Dr. Sawsan is Advocacy Advisor. She's the CEO and founder of AlignnEficient Health Consultancies, and she lives here in UAE. And then we will start by my wonderful colleague and friend, Dr. Julie Grallo. Dr. Julie Grallo is the Chief Medical Officer and Executive Vice President for the American Society of Clinical Oncology, ASCO. Julie is the Executive Vice President and Chief Medical Officer for the ASCO, and she's also Professor of Medical Oncology and Global Health at the University of Washington School of Medicine. Please, you can read as well about all the speakers in your package. And I would like to welcome Julie to give us an opening talk for the enabling effective communication, with focus now on enhancing communications with colleagues and patients through multidisciplinary cancer care. Thank you so much, Julie, for being with us.
And welcome to everyone who is in the room and online. So Rola, congratulations on your Women's Imaging and Leadership Lab, your WIL. What Rola asked me to speak on is enhancing communications with colleagues and patients through multidisciplinary care. You all know what team-based care is. I think pretty much everyone in the room would agree that multidisciplinary care is critical to get the best outcomes in cancer. On the 1-year anniversary of the war in Ukraine, I put up this picture, which is a tile mosaic outside the National Cancer Institute in Kyiv, Ukraine, that's called Fighting the Crab. And I like this picture because it shows the whole team that is required in order to fight the crab. And you see a whole group fighting that crab down in the bottom. My radiation oncology colleagues always say that must be a radiation oncologist leading the way with that beam of light. But when I ask the medical students, when I've used this in a talk, who is it that should be at the center of the care? They say the patient. And I think we're going to talk about that, how the whole team comes together, but the patient needs to be the center. I did not realize this until preparing the talk, but in 2016, the U.S. National Cancer Institute and the American Society of Clinical Oncology, the organization that I'm the chief medical officer for, had a workshop called Teams in Cancer Care Delivery. And it was several days of meetings. Out of it came 19 papers and 4 invited commentaries in the Journal of Oncology Practice. And there are some really great articles I enjoyed reading over and preparing for this talk. So the working hypothesis was that identifying and enhancing team interactions will help improve cancer care delivery. And it was multiple stakeholders, including clinicians and researchers, oncologists, primary care physicians, and patient advocates, among others. One of the key tenets that runs throughout this workshop is that effective communication is a requirement in the teamwork necessary to deliver patient-centered and value-based care. And they came up with the 8 hallmarks of effective teams. They somehow managed to get all of them to start with a C, so they call that the 8 C's of effective teams. And number 1 was communication, okay? And it included cooperation, coordination, cohesion, a collective efficacy and a collective identity, cognition, and coaching. This was a great article that's included in that workshop and that special issue. And it's entitled, Moving Toward Improved Teamwork in Cancer Care, the Role of Psychological Safety in Team Communication. And it points out 5 factors that impact the team's psychology that are applicable to cancer care delivery. 1, familiarity. Does the team know each other? Are their relationships built? 2, clinical hierarchy and the related status. So the amount of education, the experience, your position within your organization and the team. 3 is geographic dispersion. Are the members of the team co-located? Do they interact personally, or are they geographically dispersed, as can frequently happen when we're caring for patients who come from more rural areas? Boundary spanning. So you've got providers and patients and staff that are within the team, but you also need to interact frequently outside of the team to get the best care and bring maybe a geriatric consultant or palliative care consultant, et cetera. And then the leader's behavior. The leaders of the team clearly impact the psychological safety of the team, and the leader's actions shape the climate and behavior of the group. So a key principle is that teamwork in cancer care requires high quality communication, which depends on the psychological safety for all the team members, the clinicians, and the patients. And this is still from that same article that's referenced here. So the definition of psychological safety in this context is the perception of interpersonal threat and consequences of taking risk. And risk can exist, for example, when you expose yourself by asking a question or providing input or seeking feedback or reporting a problem. There can be risk there clearly, or making a suggestion. Now, if the interaction or the setting is perceived to have minimal interpersonal risk to the person involved, if it's felt to be psychologically safe, then an individual is going to share thoughts with less worry or negative consequences. They'll be more of a participant in the team. But if the setting is perceived as psychologically unsafe or risky, they're less likely to share. And healthcare providers who feel more psychologically safe when you have healthy teams are more successful in implementing new clinical practices, learning new techniques more efficiently, making more medical error interceptions, and engaging in greater quality improvement efforts. So I thought this was a very important piece we don't talk about all the time, is what is the psychological safety status of our team and all the members in it. This is also another presentation that was made at this NCI ASCO Teams in Cancer Care Delivery Workshop. This is from Mary Lou Smith, a patient advocate, breast cancer patient advocate. And she emphasized to the whole group that the team approach starts with agreed upon goals and asks the question, does the care team include the goals of the patient? Do we ask the patient what their goal is? Do we ask them what meeting that goal would look like? Do we recognize a patient's goals can change over time. And a patient's choice not to be screened for our imagers in the room or not to be treated acknowledges the reality of different patient preferences in the goal setting. Okay, so we need to respect and recognize that the patient's goals are key here. Now, just to stress that patient-centered approach, I show you ASCO's current quality care initiative. We have done a lot of work with our quality oncology practice initiative, COPI initiative, and we're piloting this new, more extensive approach we're calling our ASCO Patient-Centered Cancer Care Certification Pilot. So practices that want to get a certification and show that they are practicing high quality care can participate in this program. So it is a pilot right now, ongoing in the US. We have 12 practices that span 88 different sites with over 500 physicians. And right now we have 2 payers involved because ultimately we're trying to work with our insurance providers about if a patient and their if a practice shows that they're meeting all the criteria for APC4, then they will not be required to do things like pre-authorizations for work, or they won't have as much argument with the insurance company about being covered for that work. So again, I point out here, right in the middle, the patient is in the center, patient-centered care. There are 7 domains that come out of something called the Oncology Medical Home, and the reference for the Oncology Medical Home standards here. And of those 7 domains, you'll notice that equitable and team-based care is one of them, of which there are multiple criteria that a center and a group will have to meet in order to get this certification. In 2017, ASCO issued a consensus guideline on patient-clinician communication. And this is from an article in our patient-facing website called cancer.net on improving communication between oncologists and people with cancer. And there's a nice podcast that goes along with this. It's only about 20 minutes if you're looking for something interesting to listen to. And this comes out of that recommendation. These are the key recommendations, and there are lots of sub-bullets. If you're interested, you can go in and read this paper. But again, communication is number 1 here. Core communication skills are key. And then discussing goals of care and prognosis, discussing treatment options, including clinical trials, discussing end-of-life care, using communication to facilitate family involvement in care, communicating effectively when there are barriers to communication, discussing cost of care, meeting the needs of underserved populations, and then clinician training and communication skills. So under each of these 9 topics are a subset of recommendations you can refer to. Just one slide on differences between genders in medical communication. And this is a meta-analysis from 2022. It was then updated in 2013. But I think many of us recognize this, but this is looking at the research on it, that female physicians engage in more communication that can be considered patient-centered, and they have longer visits than their male colleagues. And this is shown in research and with data. Significantly more active partnership behaviors occur, positive talk, psychological counseling in a clinic visit, psychological questioning, and emotionally focused talk. Medical visits are about 10% longer for female physicians compared to male. And even though 10% might not seem very long, that adds up over the course of a busy working day. And what was interesting was there were no gender differences in the amount, the quantity, or the manner of the biomedical information given. So what was different was on the emotional partnership, psychologic side. And I know you're going to have talks later in this session on well-being and all. I just show you, this is from the U.S. National Academy of Sciences, a lovely paper on factors affecting clinician well-being and resilience. But you can see, if you look at this graph, that again, the center is patient well-being. A focus on enhancing patient well-being will come out and it'll impact the clinician-patient relationship and then impact clinician well-being as well. And I've spent the 25 to 30 years of my career partnering with patients. Here's something that we created back in 1995, an organization called Team Survivor Northwest, which really was to try to help patients who had cancer or were still undergoing treatment, or maybe were done with treatment, to get exercise and fitness in their life. And the point of this, in a lot of ways, was to facilitate patient-patient communication. So we've got provider-patient communication, we have provider-provider communication. This was a support group, but without sitting around a table, but being out active, walking, running, climbing mountains, in order for women who have all experienced cancer to share what they're going through and help each other. And then globally, as a professor of global health, I've also been involved in partnering with patients and improving cancer care globally. At the 2017 World Health Assembly, where a cancer resolution was passed, one of the statements was that we should continue fostering partnerships between government and civil society, building on the contribution of health-related non-governmental organizations and patient organizations as one of the steps in how we're going to impact cancer care globally. And as part of that, we've created a group called We Can, the Women's Empowerment Cancer Advocacy Network, starting in Ukraine in the early 2000s, and then being invited into East Africa after that, where every year or two we bring together 10 to 12 countries, the patient advocates with breast and cervical cancer, to talk about what they're doing and empower each other. So empowering, connecting, and educating cancer patients to improve cancer outcomes globally is the purpose of We Can. And I'm excited that our March 2020 Malawi We Can meeting, which you can understand based on that date has now been delayed because of the pandemic, will occur in May of 2023. So we're coming back together for the first time. You're also having a talk on AI. And so I asked ChatGPT, what do you think about enhancing communications with colleagues and patients through multidisciplinary care? So what ChatGPT said, I know it's very small, but they said there are opportunities for oncologists in multidisciplinary cancer care, including improved collaboration with colleagues, enhanced patient-centric care, and access to new treatments, because the team at Tumor Board, for example, might recommend the newest treatments in clinical trials. The benefits of multidisciplinary communication in cancer care, according to ChatGPT, are improved treatment outcomes, reduced treatment burden, and enhanced patient satisfaction. So couldn't have said it better myself. I'll close with this quote from Ellen Stovall, who sadly died of metastatic breast cancer. She was the president for many years of the National Coalition for Cancer Survivorship. With communication comes understanding and clarity. With understanding, fear diminishes. In the absence of fear, hope emerges, and in the presence of hope, anything is possible. So let's all work together to achieve optimal communication and optimal cancer care for all of our patients. Thank you.
Thank you very much, Dr. Julie Groh. Very strong start for our session on enabling effective communication. Thank you very much. Very inspiring indeed. Thank you. I would love now to introduce Dr. Derek Muradali, and he is the Associate Professor of Medical Imaging, Head of the Division of Breast Imaging, University of Toronto, a Radiologist-in-chief, and he is also in the Ontario Breast Screening Program in Canada. Dr. Derek is an author of multiple publication and book chapter on breast imaging and ultrasound, and has lectured extensively on these topics. His main area of research include ultrasound contrast agents in the breast, as well as the technique involved in improving breast cancer staging. Can you please help me welcome Dr. Muradali to speak on his topic? Thank you very much.
Second talk will be by Dr. Natalie Whiting. She's my colleague in Peterborough, where I practice at PRHC. Dr. Natalie Whiting is a palliative care physician in Peterborough, Ontario, and assistant professor in the Department of Family Medicine at Queen's University. She's a graduate of Queen's University Medical School. She completed her family medicine residency at UBC and a palliative medicine fellowship at University of Ottawa. So help me welcome both speakers on this very important session. Thank you very much.
Good afternoon. I'm Derek Muradali. I'm a radiologist from Toronto, Canada, and I'd like to thank the organizers for inviting me to speak today. Today, I'm going to speak about mammography recalls and what we should say to patients when we call them back for an abnormal mammogram. These are my objectives, and I have no conflicts of interest and no disclosures. So I live in Ontario in Canada, and in Ontario, we have about 2 million women that are eligible for screening in our organized screening program. And over 1 million of these women are screened in a 30-month period. So we do quite a lot of organized screening in our province. By far, most of the mammograms that we screen are normal, as we see here, but occasionally, some will be abnormal, and those patients return to our department for spot compression views or magnification views. They may get ultrasounds or biopsies, but overall, taking into account we're screening 2 million eligible women a year, many of these mammograms will be abnormal, and the patients will have to be informed of that. Well, how many are abnormal? Well, between 10 and 5% are abnormal, or now it's probably even higher. In some areas in the country, it's as high as 15% or even 20%, depending on the type of mammogram, which is quite high. And out of 100 abnormal screens, only 5 to 6 patients will have breast cancer. So the number of women having breast cancer in a screening population is relatively low. And this is our diagnostic algorithm. The patient comes in for a mammogram. She has an abnormal study, so she's recalled to the department. She may get additional views. She may get an ultrasound, may go on to biopsy or even surgery. And by far, most of the women who have abnormal screens or abnormal mammograms, they will be normal. It will be a transient event in her life, and the event will be closed eventually. But for a small percentage of these women, as I showed before, the recall will result in breast cancer, and it represents the start of her breast cancer journey. It's the beginning of the time her life has changed. So the conversation of that abnormal mammogram becomes extremely important. She will never forget it. All patients who have breast cancer will tell you they never forgot the day they got that phone call saying, your mammogram is abnormal, you need to return to the department. Depending on the conversation, it would set the foundation for her to have trust in the system, if it's a good conversation, or if it's not a good conversation, or she interprets it as trivial or dismissive, she will be skeptical about the entire process she goes through for the beginning of her journey. So the conversation about that abnormal mammogram is extremely important. Now, there are two aspects to the conversation. First of all, how do we refer to the abnormal screen? What do we call it? And the second thing is, what do we say or what should we not say during the conversation? And it's important to remember that the words we use during that conversation about that abnormal mammogram will influence her management decisions in the future. And it would also regulate her stress levels for the first part of her breast cancer journey. So let's talk about the first part. How should we refer to the abnormal screen? Well, in the imaging community and the scientific community, there's a bit of a discrepancy between radiologists and scientists as how they refer to that abnormal mammogram. Radiologists tend to call these BIRAD 0 or an incomplete examination, while scientists refer to this as a positive test. In the scientific community or the epidemiologic community, an abnormal mammogram means you've had the test, it's positive. It may be a false positive, meaning the result is eventually benign, or it may be a true positive, meaning the patient has breast cancer. Why am I bringing this up? Well, the two terminologies are very prevalent in the media, and patients hear about both of them, more so about the scientific terms of true and false positives. So let's talk about the scientific term of positives, a positive mammogram, because very often when the patients have mammograms, they'll come into the department wondering, is this going to be a false positive test or a true positive test? Well, the term positive, when we're labeling a test as mammography, is very, very confusing to patients. A positive effect in one's life is supposed to be good news, but if a mammogram is positive, it's bad news. A negative process in someone's life is always bad. However, in mammography or in medicine, a negative test is actually good news. So the concept of calling a test positive is extremely confusing to a patient, particularly if she's starting her breast cancer journey. For example, Zickman and Fisher did a study. They took two groups of women who were healthy and told them they were hypothetically pregnant. And we're going to test you for chromosomal abnormalities and tell you about your risk. In one group, they gave them a numerical number and said, you know what, your risk is 10 in 1,000 of having an abnormal pregnancy. And in the other group, they gave them a label. They said, you know, your risk was abnormal, or your risk was positive, or your risk was negative. And what they found was when they told patients a number, they all reacted the same. When they put the term positive or abnormal in front of the risk, the women had a greater perception of risk and they wanted more interventional procedures as amniocentesis. So using the term positive has an extremely emotional response to women, and it can amplify the perception of risk. It can also change it to a binary outcome saying this is either good or bad for me. And you have to remember, we're telling women that they're getting a positive test and it's coming from an authoritative figure. So they're looking to us for guidance. And it can really affect their consent processes and their shared decision-making processes if they feel they have a positive test being told to them by an expert, and it will affect their treatment decisions. In some cases, the women over-test. In other cases, they may under-test or delay testing because they are so stressed. So the term positive is actually a very, very concerning word to use when we're speaking about it to a patient about their abnormal study. What about the word false positive? In mammography, the word false positive is all over the media, and women come into our department saying, I wonder if this test is going to be a false positive. If we actually overemphasize false positives with regard to mammography in the media or in our departments when we speak to patients, they can actually cause the woman to lose confidence in mammography. She can actually lose interest in participating in the test and be skeptical about any results coming from epidemiologic studies. So in our department, we avoid using this term false positive when talking to patients. So we've talked about how scientists refer to abnormal mammogram, and because of all the things I've said before, as a radiologist in our department, we refer to these abnormal tests as incomplete examinations, and that's what we tell patients. What about the conversation? Well, we have to remember, as I said before, the words we use in that initial conversation will influence the patient's management decisions and her stress levels, because words matter. And there's quite a lot of literature on that regarding how we speak to patients during their breast cancer journey. McAfee and their group took two groups of women, gave them a hypothetical diagnosis of DCIS, told one group you have pre-invasive breast cancer cells, and told another group you have abnormal cells. And what they found was that when they told the woman they had pre-invasive breast cancer cells, the stress levels were higher and they wanted more aggressive treatment. Omar and their group took three groups of healthy women and told them that they have a hypothetical diagnosis of DCIS and discussed treatment with them. The only difference between the three groups is that one group, they told you have non-invasive breast cancer. The other group, they said, you know what, you have a breast lesion that showed DCIS. And the other group, they said, you have DCIS, which shows you have abnormal cells. And what they found was that the women that they told you have non-invasive breast cancer all wanted aggressive treatment. And the woman who they told you have DCS, which is a breast lesion or abnormal cells, they wanted less aggressive treatment and follow-up. So the use of the term cancer affected treatment decisions, even though it was non-invasive cancer. Nicol and their group did a systematic review comparing two groups of terminologies used to describe the same disease or condition. They reviewed over 1,300 titles and 7 studies. And what they found in general was that the more medical or precise terms and the more medical jargon you used with patients, it tended to increase their perception of the severity of disease. And that in itself influenced the type of management the patients wanted. They wanted more aggressive management. The patients also experienced a loss of self-control. They had self-perception issues. Their fear and anxiety was increased, and they had a higher propensity to have time lost from work and report illnesses to their work. So the use of these strong medical terms and jargon affected their self-esteem, and it's affected their consent processes in terms of further management and treatment. So what should we say regarding the recall? Well, in our department, we've taken all these considerations into account. And what we tell our nurses and our navigators who call patients is we tell them that your mammogram showed something and we need other tests. We need to continue the study. It was not quite normal, but the study is not yet completed. And that's what we say. We don't say the word false positive. If she wants to know, can this be cancer? You be honest, and we say, yes, there is a chance of cancer, but it is a small risk. And if it is positive, we're so happy you had the mammogram because we have a team of oncologists and surgeons waiting here for you, and we refer them immediately. So they know that there is a whole community there to support them. We do not use the word false or positive when we're speaking to women unless we are asked about those terms. Using the words false and positive can be confusing to patients. It can affect their confidence, as I've shown, their consent processes, and for compassionate reasons, we will not use those terms. Thank you very much. And again, thank you for the organizers for inviting me for the conference today.
Thank you, Rola, for the privilege of presenting here this evening. As Rola mentioned, I'm a palliative care physician for nearly 25 years, now working in Peterborough, Ontario, Canada. And today we'll be speaking about initiating conversations at transition points in care, particularly points at which we need to talk about de-escalation of therapy or cessation of prior therapies. This is a different kind of conversation than the one that was spoken about before me, because in most cases it occurs with a patient with whom you have a prior therapeutic relationship. And in this way, I would encourage you to approach this conversation as more of a two-way exchange rather than a one-way delivery of information. I am going to speak about 2 possible approaches that you can use to improve on your current approach to breaking difficult news, and then about a few short strategies that we as healthcare providers can use to address the impact that having difficult conversations with patients and families may have on us. Some of you may have heard about the SPIKES approach to breaking bad news. This is a 5-step approach created by a Canadian oncologist called Dr. Robert Buckman. SPIKES is an acronym that is represented on this slide. SPIKES is the approach that I most commonly use to teach medical students and residents about how to break difficult news. And I use elements of this approach in almost every difficult conversation that I have with patients and families. Today, I'd like to focus on the 2nd step in the SPIKES acronym, the P for perception. This is the step in which we ask a patient to share with us their own perception about their illness, their treatment, and their expectations for the future. You will notice that the P comes before the delivery of other news. You will notice that the step of checking patient perception comes before the delivery of the difficult news. That's why I like to call this step ask before you tell. This is the step that I find physicians least often utilize, but that I personally find the most useful. In this step, we invite the patient to share with us their current understanding of their illness, their treatment, and their expectations for the future. There's a strong tendency to avoid this step, I think, for two reasons. One, because we fear that we will open Pandora's box, and secondly, because we fear that the response will take too much time. I often use language like this to initiate this step. In order for us to have the most productive conversation today, it would help me to know where you are starting from. Can you tell me what you already understand about your cancer and your treatment? Or perhaps, in order for me to give you the information that you need, it would help me to know what you already understand about your cancer. This step is truly a gift to yourself as the care provider. The patient's response sets the stage for the rest of the conversation. It tells you what their level of comprehension is, what kind of language they use and understand, and how difficult or smooth the conversation may be. This step tells you if you can simply move forward with a common and shared understanding, or if there is a large divide between your perception and the perception of the patient, in which case you are going to have to proceed more gently and perhaps even take more than one conversation to accomplish the goals that you had for today. But in the end, this step does not take extra time. In fact, it saves time. And it helps to avoid those awkward conversations that we have all had with patients where we get to the end and realize that we just were not on the same page. Now I would like to move away from the SPIKES acronym and talk about another approach to conversations which I find a bit more intuitive and that lends itself particularly well to conversations about de-escalation of therapy. This is a three-part conversation with the format wish, worry, and wonder. In the first stage, wish, we identify the goals of treatment and the hopes that you as the physician and the patient shared for its success. In the second step, worry, you share your observations of how things have been going, or perhaps concerns you have that things are moving in a different direction than you had initially hoped. In the third step, wonder, you invite the patient to share their observations with you and begin to envision an alternative path forward together. For example, a conversation may look like this. When you first started this treatment, I recall it was our wish to extend your life so that you could spend more time with your young grandchildren. I'm concerned that the treatment has been harder on you than we expected, and I worry that you are spending more time in the hospital rather than with your family. I wonder if you have similar concerns and would like to speak about them. Or I wonder if we could talk about what your care would look like if you chose to stop the treatment. Breaking bad news is a complex task. It is a lot to expect of ourselves. We have to find words that are accessible, that are kind, that are empathic, and that are honest. And then we often have to absorb a strong emotional response and carry on and complete the conversation. And sometimes we even add the pressure that we have to complete it on a hopeful tone. As you know, sometimes it goes very well, and sometimes it is exceedingly difficult. None of us, no matter how many times we have done it before, can do it perfectly. This is the kind of work in medicine that impacts us as providers, yet we rarely slow down long enough to acknowledge that impact. So I want to talk today just a little bit about how to recognize and just begin to address the impact that sharing difficult news can have on us. I think the first step for all of us is to reflect on the aspects of these conversations that are most difficult for us on a personal level, the ones that stick with us, that we carry with us after we go home at night. This will be different for everyone. Perhaps there is a certain demographic of patient that troubles you, younger persons, people with young children, or persons that you identify with on a personal level or who remind you of a family member. Maybe there is a certain emotional response in the patient that you struggle with. For me, I know the most difficult emotion that I struggle with is when a patient responds with anger, a refusal to accept, or a plea for you to please find another trial or treatment for them. It is once you have identified your own triggers that it makes it easier to start to acknowledge the interaction or the toll that an interaction has taken on you. So the next question is, once you have recognized this, what can you do? There are 2 short practices to reduce vagal tone that are easy to use in the course of a busy clinical day. The first one is what is called vagal breathing technique, and this has been well studied and actually shown to reduce the sympathetic response that we have when we are under stress. Vagal breathing, in short, involves lengthening the out breath relative to the in breath and gradually increasing the length of the out breath over time. You don't have to breathe for 5 minutes, 10 minutes, 20 minutes, just 5 or 10 short breaths done in this way, scattered throughout your day, have been shown to increase your vagal tone. The other is a practice created by MindWellU called Take 5. This is a schematic of the Take 5 approach. It is a brief mindfulness practice that can be done anywhere. Take 5 has been shown to increase focus and attention while improving stress and resilience. In addition to strategies that are brief and can be incorporated into your clinical day, there are also strategies that we can use later. The first is to debrief with your clinical and interdisciplinary colleagues. It is unusual in medicine, and particularly in oncology, that we convene interdisciplinary boards of people, which we in Canada called tumor boards, to help us make difficult clinical decisions. But we rarely convene together as colleagues to discuss clinical interactions and troubles with communication. This can be a very valuable method of feeling less alone and sharing experiences and knowledge with your colleagues. Some people also engage in reflective writing. This can be anything, Some people also engage in reflective writing. This can include anything from journaling to creative writing, to simply writing a few words at the end of your day to encapsulate how you are feeling or what the clinical day was like for you. It's an excellent approach to help you process difficult interactions and help you tune in to the impact that your day has had on you. The third is to reflect on the ways that difficult conversations are hard for you and to seek ways to improve your communication skills. When we feel that we aren't good at difficult conversations, we often protect ourselves by creating a distance between ourselves and our patients. Unfortunately, this tends to worsen the outcomes of our conversations. Sharing difficult news is a task that can be learned and improved upon with education and practice. So in short, I hope that you will remember a few of the tips we've discussed today: to ask before you tell, to try, wish, worry, and wonder as a framework for conversation, and to tune in to yourself, to help recognize the impact that these conversations may be having on you, and identify some small ways that you can address them in the context of clinic or after you've gone home for the day. Thank you very much for joining me. and I look forward to reconvening with you during the panel discussion later today.
Thank you very much, Dr. Natalie. I'm actually amazed with this panel. I don't know about you guys, but I mean, I think we started very strongly with Dr. Julie she hammered about communication, and then we understood more about not just what to say, but how to say it, and the empathy that both Dr. Derek and Dr. Natalie was saying. And I think to round up this amazing panel and workshop, I would like we would now speak about what actually patients expect and need to know an inclusive cancer care, and that would be delivered by the amazing and beautiful Mrs. Tanya Kohler. She's a mindset coach. She's a speaker, author, entrepreneur, radio and TV personality. She comes all the way from Canada. She actually is a bestseller author of Breaking the Stupid Mold. I would love to read that, by the way. And she hosts the Mindset Mentor radio show and podcast. I believe this is how you met with Dr. Rola. And also, I'm amazed to know that she is the co-founder of Awaken Infant Magnificent, a health and wellness conference designed to elevate humanity. Wow. So please help me welcome Ms. Tanya to the podium. Thank you.
Excellent. Well, thank you so much. It's my pleasure to be here. Completely delighted to be joining you guys live in person. I'm from Canada, so this is my first time in Dubai. Very special to be here with all of you. And thank you to Dr. Rola. Yes, she was a guest on the Mindset Mentor radio show, and she was phenomenal. Loved her energy, her knowledge, her information, and her passion for what she does. And truly, when it comes to the work that I do want to elevate humanity, which I know everybody here is doing already in the work that you do. And so today my talk is what patients expect and need to know, inclusive cancer care. And I can imagine that throughout. So I can imagine that a question that you all have or you may wondered about, ask yourself the question, what do patients really want? Are you being effective in the communication and in asking the goals and asking the right questions, delivering the right information? And so today, my goal is to answer that question for you. So what makes me qualified to answer that question? Because that's a big question, right? So, and I'll tell you, so that I have interviewed many cancer patients from beginning stages to terminally ill patients to get that information. Getting a little emotional because so I lost my father to cancer. And thank you. I watched my dad struggle through cancer, and thank you. So my father was diagnosed with cancer and given 3 months to live, and he lived a year and 3 months. And I think, it was his will and his hope to live. So I think it's so important, the work that you do, the communication, as you beautifully said, Julie. Wow, I didn't expect to be this emotional. Okay, so we just go with the flow, right? And so I also co-authored a book called Cancer Heroes, and it is a book that is co-authored by several patients. Each chapter is a woman's story who has gone through the process of cancer. And I don't know why I'm crying, because I honestly believe that having cancer was a gift. And it's, most people will probably think, well, what are you talking about? How could that be a gift? Well, I know that our biggest and greatest challenges in life are our biggest blessings and our gifts. So it's a gift for me to be here today to share with you and to help other patients sort of understand the journey. We learn from each other. And actually, that's one of the reasons why I wrote a book, because I love personal development. I always have. And I think that, we all do learn from each other. And I just felt compelled to share my story of all the information and knowledge that I've learned. And that's why, I think really leads me to, one of the most important things in terms of what a patient wants and expects to know, which will be my first key factor. But I also want to let you know that in 2021, I was diagnosed with breast cancer. So I can tell you exactly what a patient wants, expects, and needs to know. And that's me, by the way. Lost all my hair. And so this is funny because I took that picture just for my own purposes because I noticed that my eyebrows were disappearing. And I just wanted to see what they look like. I thought, whoa, this is changing quickly. So what I have found in my research and my own personal experience is that there are 5 key factors that every patient expects and needs to know. And the first one is about information. So really important to thank you, to get that information across because the process can be daunting and a patient has no idea. It's like a GPS health system, right? You've got the direction, but the patient is lost. So providing that information is so integral. That guidance, the resources that are available to the patient, the different treatment modalities. I know that you touched upon some of those, throughout. And it's so important because you all know that information so well. But again, a patient is sort of left wondering. And of course, if they're like me, they're going to research, they're going to, consult Dr. Google and get all the information. But we need the right information, the facts, right? And the testing phase, that's really important because, obviously there's a lot of questions that a patient will have and they want to know what the results mean. And the follow-up is so important. One of the things that I thought was kind of interesting was that, I was asked some questions and every time you go in to get the next checkup, there's always a list of questions. But then I often found, well, why is nobody actually following up when I've answered yes to, some of these side effects, right? It's just routine. They're going through the routine. So I get that and I understand that, but I thought, well, where's the follow-up? Right. So I think that's one thing that could have had, just a little bit more emphasis on. And then, we head into the next key factor. And if I can get the clicker to cooperate, I'll take you there. There we go. Okay. So we're past that. Okay. So we're going to head back and we're going to go to options. If you guys can help me there, you guys are amazing because she's doing all the work. Okay. Here we go. So options, super important. Now I chose to have a lumpectomy versus a mastectomy. So that was my choice, although that's not what was recommended. It was recommended to have a double mastectomy. But as far as options go, it is really important because that communication factor of the goal, of what a patient wants, as Dr. Julie had mentioned earlier, is really, really integral. It was a big one for me because I looked at it as that they're just going for the worst case scenario. So they're going to go with the most aggressive treatment. And believe me, listen, I understand it. I know exactly why they said that was the best route, but it wasn't the best route for me. So I had to weigh my options in my own personal experience and what I am ready to deal with and what I choose. So that's really important. And of course, chemotherapy, is that an option for people? Is it going to be effective? I know that for my father, he was on he had stomach cancer. He was on chemotherapy to treat that. And then at some point it no longer worked. And they said, well, we can try this type of chemotherapy, but it's actually for the liver. So it's probably not going to work, but it's up to you. And he said, yeah, let's do it. He was always very optimistic and he needed those options. And I think that's one of the reasons why he lived a year longer than anticipated, because he had hope. Options equals hope. All right. So few more modalities there. Again, the hormone therapy. I again chose not to do that because I, didn't want to deal with all the side effects. Quality of life is certainly important, to everybody, but I had to weigh those options. What I do, my mind is extremely important to the work that I do, the cognitive abilities. So I didn't want to sacrifice that, for that treatment. Biological therapy. Again, these are therapies that we don't all all, know. So it's just about getting that information that you have. And the next key factor is support. Now, this is another huge factor for me because, when I was speaking with my potential radiologist, I kind of, advised him that it's not really the course that I want to take. And then he had said that, well, how about, you have the surgery. And by the way, I did 14 rounds of chemotherapy first, and then I had 2 partial mastectomies on the same breast. And so, when he said, like, after surgery, let's regroup and we'll talk about it. Sure, I'm absolutely open to a conversation. I am open to that knowledge. But then I had decided after the surgery that I did not want to proceed with radiation. And I'll never forget what he said. We talked about, you're never going to forget what, the doctors say to you, the good and the bad. Well, what he said to me was that I'm making a mistake. And again, I respect his opinion and his expertise, and I understand. I get it. If I was him, I'd probably try to convince me as well. But I had made up my mind, and I felt that it was a little bit shocking. So what he said was, you're making a mistake. And he says, okay, well, first of all, he did ask me why. And I explained my situation. And I said, I'm going to support it nutritionally, with supplements. And I explained a little bit further. And then he said, well, I've seen every diet there is, and they never work. And yeah, right. I thought, okay, well, I never said once that I was going on a diet. I said I was supporting it nutritionally. And that's the difference. There's a difference to me, right? And so I just thought that, that was an interesting response. And again, patients, people they may not remember everything that you've said, but they're always going to remember how you made them feel. And I can tell you, I did not feel great after that conversation. And so one of the doctors, his name is Dr. Mark Mancola, that I absolutely love. He was also a guest on my radio show. And it's a book called The Way of Miracles, and a documentary called The Way of Miracles that tracks his patients and the healings they've had, even through some terminal, cancers and what have you, but incredible. And one of the things that Dr. Mancola has, I think that really makes a difference, is the next key factor. It is a superpower, and he had that in spades. So it's interesting because Dr. Mancola, although he is a quantum energy healer, he's a naturopathic, he's not an actual naturopathic doctor. He's, I can't remember specifically, a nutritional therapist as well. So, but, he was not really into chemotherapy or radiation, right? But he never once questioned my decision. He always supported my decision, and he made me feel fantastic. So that support is so integral. And here is the superpower that Dr. Mancola had, is listening. This is, I think, one of the most underrated skills of all time, but it is your most valuable. It is your superpower. So there is hearing, and there is listening. So according to Merriam-Webster's dictionary, hearing, the process, the function or power of perceiving sound, right? Specifically, the special sense by which noises and tones are received as stimuli. So we've all got that going, right? Most of us. So then there's listening. So listening is to pay attention to sound, to hear something with thoughtful attention, to give consideration. So many of you will maybe ask the question, is there really a big difference? Well, I'll tell you, to Coco, there is a huge difference. And Coco was diagnosed with cancer at the age of 25. Her radiologist wanted to treat her very rare cancer aggressively. So in that process, he over-radiated her. And from her breasts down, she was completely burned her organs, and she can no longer be intimate in her entire life. She's also a mom of a young girl, and she now has 2 tubes coming out of her back, and that's how she goes to the bathroom, because she was over-radiated, despite the fact that she had said that she was burning And her radiologist said, well, we need to treat your cancer aggressively because you have aggressive cancer. And repeatedly, she says, I think we need to stop. I'm burning. And he didn't stop because he was not listening. He was not paying consideration, like attention. And I'll tell you, is there a difference? Well, if you ask Coco, there's a world of difference. All right. So, that takes me to, the next key factor is compassion. We're running out of time probably, right? Yeah. Okay. So, I think we all know what compassion is, but as medical professionals, delivering the awkward news, dealing with patients who are struggling and who don't know how to, handle maybe their pain and suffering can be very challenging. So if you can't take on, the emotional aspect of what your patient is going through, just look at perspective taking, thoughtful, consideration versus emotional, empathy, right? There's a difference. You want to go with the cognitive empathy that can actually help you as well. And so, the 5 key factors are so important. And I just want everybody to recognize how valuable you are. Even the radiologist who I didn't agree with, I respected, where he was coming from. I understood it, but I chose something different. And I know that you all do amazing work. And so keep doing the great work, because as patients, we need you. We rely on you and we respect you. So the next time you're treating your patients, I just want you to remember the 5 key factors that every patient expects and wants and needs to know. And that is the right information, because you're the experts. We want options because that gives us hope. And we need the support because that means everything. And that active listening, you can help turn someone's world right side up with that superpower that you have. You all have that. And the compassion that, again, it just helps to elevate humanity and to make everybody, feel supported and validated wherever they are in their experience. Thank you.
Thank you so much, Tanya. This was amazing. Eye-opener for a lot of healthcare providers. And first of all, I congratulate you on sharing your experience with us. It means a lot to me and to everybody in the room and to the audience. We learn a lot from our patients. And I think the shift in healthcare in the past 10 years is the fact that patients are included on the table for decisions. And I think probably most of you agree on this. Like, we really have to listen to their choices and respect them. We need to help patients make informed decisions, but I think we shouldn't judge. Yes, we worry and we really want the best for our patients, but sometimes patients know better than us because they know how would they feel. So again, thank you so much. We're moving to the panel discussion. Please submit your questions for the virtual audience on Zoom, and we'll share them. But I will start with the one question first, and then I'll take questions from the audience. Julie, actually, this is a question for you. And probably from reflecting on the communication session, in tumor boards, we have multidisciplinary, all the way from oncologists, surgeons, radiologists, radiation oncologists, nutritionists, psychologists. We have so many brains in the room. And in a field where evidence-based medicine is moving so fast, some people are catching up, some people are in the middle, some people are convinced, some people are not. And I'm sure you've been in that position where people have 2 to 3 different opinions. Probably we narrow them down to 2 opinions, and both are like with high stakes. And now you are the physician who's going to take this to the patient. How do you handle that? And how can you give us advices on how to actually break that news without confusing the patient? Thank you.
It's a great question, Rola. I think sometimes we have clear evidence where a question has really been answered. And lots of times we don't, or we have multiple options. And I think that gets to the context of everything we've been talking about in this, which is that, trying not to confuse the patient, but giving them some choice in the matter too. Because sometimes that, you might say, well, this treatment approach might give a 30% chance of response, but a 20% chance of high toxicity. But, we weigh all those things, and we don't want to use those numbers in front of the patient. But starting out by asking, which we heard about from our palliative care colleague, what are your goals? What are your fears? And, I've had patients make choices to take an oral chemotherapy that doesn't cause hair loss sometimes, even though an intravenous treatment might have scientifically a little higher response rate, because that hair loss and having everybody out recognize them without hair as being a patient with cancer was the most important thing for them. So I didn't entirely answer your question, but I think this is where there's frequently multiple options, and knowing how to condense it and distill it and understand where the patient's coming from can help you make that final decision.
Thank you so much. So at the end of the day, we went back to the patient and had the patient make the choice, and we were kind of the conduit of the big tumor board, and we have to, in a very honest and sincere, without judging, transfer the opinion and help the patient make a decision on her own or his own. I think that's great. So can we take some questions from the audience? Any questions? So.
Well, I have a question for both of you, actually, for Julie and for Tanya. How does the patient take the answer of the doctor as I don't know? Because at the end of the day, doctors sometimes don't know. So how would you manage something like this? I mean, especially in those types of cancer that a bit aggressive, internal, we don't have like the whole thing about cancers. You don't have like 100% info about anything. And for the patient, you're the hope, and you're the doctor. You're the god of everything by that time. So how to manage?
Well, that was a great question. And right away it brought to mind a time where I remember that my white blood cell counts were really low. And so, the next session of chemotherapy was kind of on hold. And I was doing bone injections to boost, right, and to elevate that cell count. But for some reason, my doctor said that it's not working. She has no idea why. It should be working, but it's not. So we went from one needle, one injection. It was after every chemotherapy session, right? And then it went to one every day for 5 days after chemotherapy, and it still wasn't working. And then we went to 10. So for 10 days after chemotherapy, to do, and I was doing chemotherapy at that time every 2 weeks. But what I actually really respected was that the oncologist said that she didn't know. And she just said, well, we start with 5. And then, we go up to 10, but we don't really know. But that was actually really key for me, because I was able to make a decision to not take the bone injections for 10 days in a row, because it really wasn't working to what they wanted. And then the day before chemotherapy, I still needed an injection. So I skipped the 10 days. And the day before chemotherapy, I would, take the injection, and it would elevate my white cell blood count enough for me to have the chemotherapy. And the reason that I love that is because I was getting a lot of side effects. I got like all those, nasty side effects from the bone injections, right? So I thought that was really helpful. So as a patient, you want to know what the doctor doesn't know. I love that, actually. So I think we don't expect you to have all of the answers, but, we do, want you to share what you know. And then if you don't know, that's great. I really value that. So as an I don't know, there's another time where I was part of a clinical trial because I, checked off all the boxes for a particular study. So of course I want to help and support that. And then they said, well, these results came back. It was not hereditary cancer. Nobody in my family has breast cancer, but I had a gene that if I had a son, which I have no children, but if I had a son, then he would have a 50% chance of having prostate cancer. Right. Yeah. Right. And then I remember when they were telling me the results, they did say, well, and we don't really know what this particular gene does. Like, we don't know, because it was another gene as well. It's just a fact. Exactly. And that's okay. I was actually okay with that information because I think it's just valuable to have awareness. And again, we don't expect you to have all of the answers because nobody on this planet, and there's 7.8 billion people, nobody has all of the answers. So we just want the truth. That's my take on that. Yep, absolutely. Yeah, well, yeah, because I think doctors, medical professionals, I mean, you're treated as gods, right? It's like, oh, they've got all the information. They're going to fix me. They're going to make it all better, right? Yeah, and that's not realistic. So that's my opinion. I think, are there people that expect you to know all the answers? Yeah, there's probably a few. There's probably a few out there. But that's my take on that. I found it very valuable. I want to know everything that you know, and I also want to know what you don't know, because then I can do my own research and I can be better informed. Yes, absolutely.
I'm glad to hear that hearing I don't know is actually reassuring. I think there's so much, not just in medicine, but in life, that we don't know. And the certainty, I would frequently say, I don't know, I'm not sure, but I think that it's our obligation to say, but here's how we're going to address it, or here's the game plan. Just leaving it with, I don't know, is just going to create worry, I think. But acknowledging that there could be multiple causes. It does, I'm checking the boxes. I'm not sure what it is, but here's how we're going to deal with it, I think, is a critical component to that.
Thank you. Thank you very much. My name is Naji Al-Sagir. I don't know why you called it a women's empowerment session. This is for men more than it is for women. It's been really a very nice and educational session. Yeah, for both. I took some notes, if you allow me. First of all, I stopped by the workshop over there, and I wrote down there were 20 physicians who were mentees learning, and 20 women and 4 men only. Yeah, so a lot of women are into definitely medicine. Yeah. Now, for our colleagues on screen, I really enjoyed, the conversation. And I'm happy to know that you still do breast cancer screening in Canada, because people who are against it always quote some research from Canada. But, breaking bad news, as that you spoke about, whenever patients call us, in Lebanon, in this part of the world, people reach their doctor right away. They reach the oncologist, not even a general physician. Doctor, what is this? The mammogram is abnormal, or the biopsy shows, DCIS in situ. Unfortunately, it's still written cancer in situ, carcinoma in situ, which we really think it should be written like intraepithelial neoplasia. I tell the patient outright, this is not cancer. I can explain for her, half hour. He keeps asking, saying, well, I tell her, no, this is not cancer. This is a pre-cancer. If you leave it there, it may become a cancer. That's the way what I use to reassure, a woman. It's like, when patients ask us, you give different options, okay? We give different options. There are options that I'm not comfortable with and I disapprove of. It's not easy for me to accept, Us physicians, whatever we say, like we should disconnect, we should not get too emotional, too involved with our patients, we do get, there are times when I hold my tears when I'm talking to a patient, even at diagnosis, not in the terminal stage. You have a young woman with breast cancer, young kids, this is important. So the options, yes, it's important, the options to explain. And the other point you mentioned, I wish you add to your 5 points, time. Doctors surgeons should give more time to patients. Unfortunately, I don't think that happens everywhere. And the role of nurses here becomes very important also. But unfortunately, when the role of nurses becomes more important, the doctors don't spend more time with the patient. But that is really important. And at the end, I just want to tell you one thing, about hair loss, for instance, when women ask me about hair loss, I don't tell them you're going to lose your hair. I never use the term. I tell them your hair is going to be renewed. They love it, They like it. I like to tell the woman, you are fine. And I have had women who tells me that's what stayed in their brain, that I said they're fine. They will be fine. You explain everything, but that is really important. And the last thing, if I may, I wrote a book in Arabic called Alif Ba Thadi, Alif Ba Amrad Thadi, ABC of breast diseases. And on the dedication, I dedicated it, I said in Arabic, إلى جميع نساء حياتي, to all the women of my life. So the journalists and everyone was teasing me, you meaning, what is this? You dedicated this to your girlfriends? Well, I said, no, all the women that I treat, I love them. I consider them as, and patients appreciate that. So it is definitely important that we do, show, involvement, but we have to know how to give the correct advice, to be able to give the better advice. And using words is very important, as you mentioned.
Thank you.
Thank you very much, Doctor. Over to you, Rola.
Thank you so much, Sawsan. I'm just going to give the opportunity, because we're running out of time, to the speakers online. Natalie, do you have any question, any comment before we close the first session? Because we're moving on to the second session.
Rola, I just want to say thank you for coordinating such a complimentary group of speakers and topics. And I'm happy to answer questions after the next session if there's an opportunity.
Thank you very much. Actually, we're privileged that we have both wonderful speakers and audience, and it's actually a treat to have Dr. Naji Saghir as well with us to share his experience. And he's like one of the icons in the region. So we're very privileged. Thank you very much. Moving on to the second session, we're going to talk about the role of AI. And I would like to introduce and thank Dr. Chris O'Connor. He is the CEO of FirstHx. He's one of our sponsors for the workshop. So I really appreciate it, Chris. Thank you so much. Chris is actually a critical care physician. And he is, as I said, the CEO of FirstHx. He's going to talk to us about the role of AI in healthcare and has it moved the needle or not. Okay, so Chris is actually with us online, but we, just in case due to the technical difficulty that we can see, we have pre-recorded his session. However, he'll be available to answer questions immediately after his talk, because I know Chris is very busy. All right, so 10 minutes, and Chris, please.
Thank you very much for the opportunity to speak. This is a great honor to be invited to speak today. I'm going to speak today on a topic that I think is kind of front of mind at the moment, and that is artificial intelligence in healthcare, moving the needle, and how can we use AI to improve things. And I'm going to speak both about the challenge, both about the opportunity, and some of the challenges that we face as well too. Briefly about myself in terms of my background, I am a critical care physician. I'm the CEO of FirstHx. FirstHx is a company where we are digitizing a manual process, the medical interview, and trying to make it structured and knowledge-based. We're doing this for practical benefits in terms of empowering patients, improving quality and efficiency, and providing data to the healthcare system. But there is an intersection with AI, because by digitizing a manual process, we're going to create the data sets to help AI downstream. So that's what I am currently doing. In terms of my background, this is my second startup. My first company, Think Research. I started in Canada, grew to 8 countries, including having projects in 8 countries, including the United Arab Emirates and Saudi Arabia. Had some big hospital experiences too as a director of medical informatics. I do continue to practice clinical medicine, which I think is important because I still get to see what it's like at the front lines, and I can see how these technologies actually translate into clinical practice. The foundation for what gets me out of bed in the morning is that, and I won't belabor this point because it's pretty obvious, is that we've got huge challenges in healthcare: capacity, quality, clinician burnout. These are Canadian statistics, but from what I see, this is a pretty universal problem. And so naturally, it makes sense that when something like artificial intelligence comes along with the promise to automate and streamline and improve healthcare, that people get enormously excited about it. And this is just one example of some of the companies that are working in this space. The New England Journal of Medicine has just launched a sort of a subjournal dedicated just to AI. And I do think there's a lot of justifiable enthusiasm at this time that AI is going to make a difference. But if the opportunity is real, I still think at the same time, the hype is real. And in a way, this is not a new story. We've been listening to this for quite a few years. Vinod Khosla is very smart individual. Has been predicting the demise of clinical medicine for well over a decade now. This is a quote from 2017, but he was saying similar things in 2012. I'm sure you're familiar with Geoffrey Hinton and his comments about, well-trained pigeons. So we've certainly had high promises around how AI is going to transform clinical medicine, but there's a huge gap between the hype and what I think most clinicians experience in their day-to-day practice at this point in time. I can say in my practice, it's untouched by AI pretty much at this moment. Lots of articles. It's interesting that outside of medicine, AI is transforming our lives. It's flying our planes, driving our cars, booking our tickets, and Siri. It's a long list. So it's having a huge impact outside of medicine, less of an impact inside of medicine. And then there's things like, this got a lot of press about 6 months ago, the EPIC sepsis prediction model. And so an example of AI, and, it just doesn't work very well. And this is not the AI future that we're looking for. We're wanting AI that makes our life better and actually improves things. And so we have to do better than this if we're going to see the impact we want to see. So if we're going to figure our way out of this problem, we have to figure out, well, why is this? Why is medicine lagging other domains? And why aren't we seeing the payoffs that we'd like to see? So I think there's a number of reasons. Like any problem has many complicated antecedents. So the first is, I think we just have to put our expectations in place. People have been working on self-driving cars for 10 or 20 years, depending on when you want to look at it. Medicine is complex, and this is going to take time. And it's not like somebody's going to flip a light switch and just change this straight out the gate. I think the big foundational problem that medicine has, say, compared to self-driving cars, is the data problem. And I think this is multifaceted. So much of medical practice still remains in formats that can't be used to train AI. And we're aware that lots of it's verbal, lots of it's experiential inside the minds of clinicians, or if it's digital, it's still not in a format that's well used, that can be used effectively by AI. And even with the promise of natural language processing, a lot of unstructured free text narrative medical notes, it's just hard if you've got a big garbage in, garbage out problem. An area that I think is still very underappreciated is the complex nature of medical knowledge itself. You know, as some people might remember, Watson, IBM's Watson, beat humans at Jeopardy, which is sort of a fact-based trivia game show, in 2012. And people thought that this was spelled the end of medicine, because surely if a computer could win at a game show quiz, then it could definitely win at medicine, because it would just know all the facts. But I think, you know, 10 years later, this technology hasn't had any impact on medicine. And the reason for that is that medical knowledge, there is some simple medical knowledge, like what's the longest bone in the body? That's a simple fact. But the facts we need to know for our clinical practice are complex, and they're spread across multiple different information sources. And the reasoning is not simple factual, it's complex Bayesian. And so our medical knowledge hasn't been put into a format that's machine readable, and that's a huge problem. And then furthermore, the outputs of medical decisions are often complex, relating to diagnosis, causality, prognosis, treatment, legal, regulatory, billing. It's a complex output, and so it's not a simple yes, no answer often. And then the last leg of difficulty is the system's complicated, clinical workflow is complicated, and getting this implemented into clinical practice is often very difficult. So I think if you put all that together, complex knowledge, complex system with complex outputs, with lack of data, it's no surprise that it's been hard to do. So where do we go from here? So, you know, it's a complex problem. There's not a simple solution to this, but I think some of the foundational things we need to do is, and some of the mistakes or approaches that I see that might not be optimal is, first, start with the problem. Find the problem first. Don't start with the tool. When you talk about looking at a beautiful house, you don't start by talking about the hammers and screwdrivers. You talk about the function of the house and what it looks like. And I think the same has to be true here. Start with the problem. Don't start with the AI necessarily. And start with problems that matter, that will actually make a clinical difference. I was speaking to our head of radiology, and he said, yeah, AI can read chest x-rays pretty well at the moment, but he says, that's not my problem. I can read them very easily myself. The data, we have to focus on data. The problem with data is it's not really glamorous. It's a lot of work. It's very important. There's not a lot of glamour in it, but it's key, because without it, you can't get very far. I like the data-centric AI as a movement, which is smaller, better data sets for training versus trying to use these huge, poorly curated data sets. I think there's some promise there. You have to get all the non-AI stuff done well. The clinical workflow, project management, and clinical engagement. You need the change management, and engagement's key. And the final thing I would say that's key to get this to go, that is often missing, is clinician in the loop. So I think AI solutions that aim to replace clinicians is not the right approach, certainly not where the state of the technology is today. We have, outside of medicine, lots of examples of this. We have pilots are still in the cockpit of planes. We still have drivers in cars, and we're going to for a very, very long time. So I think we want to focus on solutions that augment clinicians versus trying to replace them. Important because it de-risks it. Humans can take liability, machines less so. And the final 5% of a solution is usually 95 or 99% of the effort. So it's easy to solve the common cases, but what do you do about the edge cases where the system's not going to work? And how are you going to develop your AI if you don't have actually humans providing the feedback in the loop as the AI is training itself? And the last point is important as well too. In medicine, things tend to be true because of who says it's true. It's not math. Like for math, 1 + 1 = 2. Doesn't matter who says it. But in healthcare, who says it matters? The expert groups, the specialty society, or just, senior respected clinicians. And so AI solutions that cut these people out of the loop, or organizations out of the loop, are going to have a hard time both being true in a sense and accurate, but they also won't be perceived as being helpful by the clinical community. So I think we really have to get the clinicians deeply engaged in the solutions from the start, and then I think we'll make a lot more progress if we do. So it's a super exciting time. I think this statement is true. The easiest part of an AI project is the AI. The AI is easy. Everything else is hard. The data, the project, the system. But I think it's a time of enormous progress. And I think we're on the cusp for the first time of seeing actual positive impacts from AI in clinical medicine. Thanks very much.
So I believe he's still with us, but he will need to leave shortly. So before I introduce the next speaker, if anybody wants to ask Dr. O'Connor. Yes, Dr. Naji? Yeah, of course.
Thank you very much, Dr. O'Connor. My name is Naji Al-Sagir. I'm a medical oncologist. Just to ask you, please, how are you addressing the business financial issue of all this? You're saying it's not meant to read a regular chest X, but hospital administrations who are trying to save money, once they know it can be read AI, they may, not hire more radiologists. What do you think of that, for example?
So it's an excellent point, and I think obviously the clinical value, the business case, the ROI is critical for technology to be adopted in healthcare, and that's sometimes overlooked. The paradox of these solutions that try to replace clinicians is that, and I'm sorry, my video camera's on the fritz right now, otherwise I'd be on the video. The paradox of these solutions that try to replace the clinician, they often create more problems than they solve and actually deliver less benefit. And I think AI solutions that work with you, and I think a lot of the people in this room can appreciate this, things that improve your efficiency, speed you up, improve the care you deliver, standardize things and work with you, that delivers real benefit with a real positive ROI. It might be conceptually nice to say we'll have the robot take over and we can replace the clinicians, but I just don't think that works very effectively in most cases when you actually get into the real world.
Thank you very much, Dr. Connor. I personally loved when you said, focus on the problem, not the tool, because I think that's where the issue as well in healthcare is, like, we get excited with every new technology that we lose focus with the ecosystem around that technology, even the capacity building of the people who should use that technology. And I think you said it it's so common sense, but we all know common sense is not common. So if there is any last question, that's the last question for Dr. O'Connor. Yes, I'm coming.
So my name is Mahmoud Hamza. Basically, I'm a biomedical engineer. I'm working with one of the healthcare vendors. It's not a place for marketing. So just I want to add one point. Yes, we are developing healthcare IT solutions. Yes, we are developing AI technologies, but AI technology will never replace the human resources or the core of the business, which is the radiologist or the oncologist or the physicians itself. So healthcare providers, we are supporting, we are trying to make your life more easy. We are trying to make it like, as what you mentioned for, let's say, the X-ray, my role is to prioritize for you the cases. Which case need more attention from you as a doctor? This is what AI is doing right away today. So if it is a TB or a pneumothorax, we can highlight it for you. We can show it like more fast that it needs an attention, but the lower priority cases you can take your time to have a look on it. So AI is a supportive tool. AI in, let's say, even if we are talking about breast screening, so AI is a part of it to help to make the life of the radiologist or the oncologist who is reading the images more easy to just highlight for him the findings. But I need the healthcare professional to tell me, yes, this is confirmed, or no, for the medical legal. We cannot do it by our own selves. Thank you so much.
Thank you very much. So now moving to, thank you, Dr. O'Connor. Thank you for your
Thank you so much.
contribution. Thank you. So now moving to the second second part of the session, we're talking about leveraging social media in the healthcare for the healthcare provider. How can social media help us? Actually, I would love to listen more about this because we suck when it comes to social media. Seriously. Except for Hiba, yes, I'm sure. So I would love to welcome Dr. Hiba Qutb. Dr. Hiba Qutb is a consultant of sexual medicine and relationship, marital family counseling. She's professor of forensic medicine, Cairo University. She's also associate professor at the American Academy of Clinical Sexologists in Egypt. She was the first in the States. It was Egypt, sorry. In the States. Yeah, I thought that would be something not here. She's a role model. She's the first Arab woman who is sex therapist and marriage and family counselor. And she launched the profession of a sexologist and the sex counselor in our region. Thank you, Dr. Hiba, for pioneering this in our very, very well needed actually in our region. She's a renowned lecturer and conference concerned of the marital and family affairs and trans globally. She's a very established author, and also she's a TV producer and presenter. Dr. Hiba, floor is yours.
Assalamu alaikum, everybody. And I'm so happy to be here with you. And special thanks to my dear, dear, dear sister and friend, Dr. Rola Shaheen. We got to know each other for like 10 years now. And we met on the, the purest spot on earth. We were at pilgrimage together. We were at Hajj together. And this is where we got to know each other. Okay, today we're, I think I'm the only person in this room who's a little bit away from the field of cancer and breast cancer and those things. But at the end of the day, it's reflecting everything, especially my field, the sexuality, the sexual health. So for today, we chose, me and Rola, like a topic a little bit away from the deep science, leveraging social media for healthcare providers. So let's skip all this. Let's go to the history a little bit. Professional healthcare personnel, from the side of the professional healthcare personnel and the patient from the other side, communication has been always an interest, affecting different contexts. The academic, the medical legal, and the commercial as well, because, at the end of the day, we do this for a living. This makes it an everlasting, up-to-date topic, being depending on the dynamic, growing methods of communication. Major part, if you don't know, guys, the major part of the medical education nowadays, especially in North America, emphasizes the right methods of communication with the patients, their relatives, their caregivers, if they're minors, equally with the medical and surgical sciences and skills, maybe more. In the program of the SMLE, for example, or the MCC in Canada, about a third of the program or the curriculum focuses on how to get in communication with the patient and the patient's people, let's say. As general facts, participation in social media by the general public has increased sharply. Let's say, and let's compare between 2005 and now, which is 18 years. It's nothing in history. It's just 18 years. The proportion of adults using social media has increased from 8% to 82%. It's more than 10-fold. Can you imagine? The use of social media is prevalent across all ages and professions and is pervasive around the world. In 2012, which is like 10 years away, Facebook users exceeded 1 billion. Nowadays, in last Jan, 2 months ago, it's reached 3 billions. I don't think it's 3 billion people. I think it's 3 billion accounts. But anyways, it's it's rising very, very sharply. I think we skipped. Yes, no. So the benefits of social media for healthcare professionals on the professional level. They can read medical specialized and non-specialized articles. I mean, you know, there are a lot of things for us as doctors or medical professionals. There are a lot of topics which are of a great prevalence for us, for our knowledge, for our practice. So listen to experts about different medical topics or non-medical topics. Research medical developments. Networking with or consulting colleagues regarding patients' issues, sharing cases and ideas, disseminating the research results and methodologies, discussing practice management challenges, making referrals, marketing their practices. And this is, you know, the thing we want to highlight for now, because it's very growing, very growing. I mean, you know, if you refer like a friend or so to a doctor, the first question is, give me his account. Is he on social media? Show me his pic. Show me his videos. You know, it's a lot. It's really a lot. Engaging in health advocacy. A growing minority of physicians in convenient specialties, of course, because not all specialties are okay for the, you know, for sharing their science or their profession on social media. Also uses social media to communicate directly with patients, to augment clinical care and to widen the circle of the target patients. And it's also from the side of the patient, the doctor is always there. You know that the doctor is always there. If not in person, so I can send my questions, so I can communicate via a video call. And of course, me personally, because I spend a lot of time in Canada at my kids, well, this gave me a great opportunity to be at my clinic while I'm in Canada. So, you know, I'm on video call and I'm communicating with my patients. Okay. On the level of research, a survey of more than 4,000 physicians conducted by the social media site Quantia MD. It's really great, this site. I mean, you guys, you can go to it. Found that more than 90% of physicians use one or more forms of the social media for personal activities, whereas only 65% use these sites for professional reasons. So nearly 2/3 of the physicians have reported participating in the social network on the professional level. However, both personal and professional use of social media by physicians is increasing, of course. Types of social media activities of healthcare professionals. You know, the doctor or the medical professional to the patients and vice versa. The most popular social media sites for physicians are those where they can participate in online communications or communities like blogs, podcasts, vlogs, online channels, and all these things. Also, doctors to doctors or medical personnel between them, exchanging knowledge and opinions, listen to experts, network and communicate with colleagues regarding patients, diagnoses and management of patients. Another example is crowdsourcing, harnessing the knowledge and skills of a community to solve problems and to gather information, opinions, mainly in research work. So it helps a lot as well, because, you know, at the end of the day, the research work is reflected on the patient's good. Social media can also be used to connect medical professionals or health professionals in less developed areas of the world with specialists in more medically advanced locations, such as viewing surgical procedures streamed via the internet, and questions can be asked online in real time. I mean, you know, on table in theater. So this is also a great thing. Online therapy is nowadays a major type of media communications. So especially in you know, life coaching, psychology, psychiatry. I know, you know, a friend who is a radiologist. He has a house in Spain. He's staying there all the time, and he gets the images online, and he's just writing the reports while, you know, on the chaise longue on you know, on the beach. How about you? Yeah. So globally, reviewing a medical practitioner includes surely how good his communication skills are. This is obviously monitored when we find the communicative, smiling doctors are attracting more patients. I mean, this is a finding by research. So how do I know that the doctor I'm going to is communicative or not. Social media helps a lot in this thing. Nowadays, it's big part of the reason why patients chose a medical practitioner over another is how smiling he is. So should we play this, please? Yes, it's playing now. Well, as personal experience, I had my own 6 TV shows since 2006 to up until 2013, I guess. And then I stopped doing my own shows, and for now, I'm showing as like a TV guest on regular basis. And this creates like, discussions, debates, arguments sometimes, and, exchanges, exchanging opinions, whether on the medical level or the, on the media level, on the press level. So again, this is really, really beneficial because, on the religious level sometimes, but this is really good actually because, this debate creates research and creates opinions about things and creates, in my field, it created actually normality of the issue of the topic. I mean now, and sometimes in lectures, open lectures, like you see now, sometimes it's like medical opinion conflicts, and it's also positive. That's what I think. But for now, the topic of sexuality is being discussed on TV shows and in radio shows and in lectures and in press. It's getting normalized. It's getting on hard ground, specialized in that field. And for now, I receive a lot of junior doctors who want to take this as their profession. Yes. Most used platforms in medical patients communication is Facebook, Snapchat. It depends a lot on the area. I mean, in Egypt, it's the Facebook. In the Gulf area is the Snapchat. Skype is frequently used for personal consultations. TikTok is really rising now everywhere. And Zoom meetings like we were today together with, these great doctors from these great speakers from North America, and Instagram, of course. It's rising in the area of North Africa for now. Okay. To summarize, social media top benefits for healthcare professionals are provide useful and accurate information, listen to patients and their complaints and concerns, initiate conversations about medical topics, advise patients to take required actions. Conclusively, thus, social media provide a new communication channel for healthcare professionals to network professionally, to share and exchange medical information in ways and at a pace that was never before possible. All healthcare professionals are advised to make social media part of their work. Please do. So this is really something now. And at last, thank you all for your listening. And it was really my pleasure. And come and visit our great Egypt.
So, disclosure. I'm an employee since 2002, and I'm planning to work till 2048. And I calculated that, so I'm 44. You can count how old I'll be when I retire. I was still burn out in 2015 and self-managed myself out of it. And I co-authored a study about burnout, which I'm going to share the result with you. And I keep myself satisfied despite the challenges. So if you see me happy, it doesn't mean I have ideal conditions. And I'm a runner. I completed my first marathon a few months ago. So I'm going to run you through because I have a lot to share and we have only 15 minutes. So we'll speak about what's burnout, epidemiology of burnout among healthcare providers, just snapshot of something that could be relevant to you, impact of healthcare provider burnout, and overcoming burnout cognitive limitation. Pull your phone because I'm going to ask you to log into our website. So what is burnout? So Slido, just go Slido in Google. And oops, okay, hold on. So Slido. Okay, so that's fine. It will not work. I always know these digital things, sometimes doesn't work. So I have a backup. So here's the question. Show of hand. Overall, based on your definition of burnout, how would you rate your level of burnout? I would read the sentence, you raise your hand. Now, if you want people to close their eyes, I mean, don't worry about what people think. I enjoy my work. I have no symptom of burnout. How many can say that with confidence? Okay, thank you. Occasionally, I am under stress and I don't always have as much energy as I once did, but I don't feel burned out. So who would fit there? Okay. I am definitely burning out and have one or more symptom of burnout. And again, based on your definition of burnout, no a specific definition here yet, such as physical and emotional exhaustion. Okay. And the symptoms of burnout that I am experiencing won't go away. I think about frustration at work a lot. So I feel frustrated most of the time at work. So who would feel that? And again, nothing to feel shy about. I'm not going to report you to the manager. Don't worry. And no one kind of really cares. So I feel completely burned out. And I often wonder if I can go on. How many times you wake up in the morning and you think, when I'm going to retire? Be honest again. Who would kind of go with statement 5? Well, you're here. So obviously, if you were burned out, you won't be here. So just to tell you, this is a one single item validated burnout survey. If you want, take a screenshot, ask yourself, answer for yourself. If you are, your choice is 3, 4, or 5, then you have burnout. The burnout spectrum, as we're going to discuss now. So what is burnout? Syndrome of emotional exhaustion, depersonalization, reduced personal accomplishment that can occur among individuals who work with people. All of you, right? So that's teachers, that's social workers, that's a humanitarian provider, healthcare provider, physician, nurses, name it, all of them. We work with people, we are at risk for burnout. End of story. Now, what emotional exhaustion is? Simply you feel the emotional demand, you feel under pressure. Depersonalization, you're cynical. So if you sit beside a colleague, they're always complaining, always negative, they're burning out, they're not aware of it. Personal accomplishment, if you undermine what you accomplish, we accomplish great work every day. As simple as if you smile in the morning when you greet your colleague, that's an accomplishment, right? Not everyone can smile. So we underestimate what we achieve, no matter how simple, how great they are. So now, when it was defined initially as a sort of occupational health hazard, so Freudenberger, when he defined burnout, he went through about 12 stages of burnout. Start with compulsion to prove. I want to fix the healthcare system. That was my mindset in 2012. 2015, 3 years later, I was burned out, completely burned out. I'll tell you in a minute how. And then you go, okay, I'm going to prove it. I'll work hard. I'll work harder. Neglect your own needs, right? And then you go till you are empty completely. You just can't push yourself. And then depression, then burnout syndrome. Now, this is another way of stages of burnout. So it does not go overnight. It builds up and we feel it, but we ignore it. That's part of burnout. You ignore your feelings, right? So now let's ask you this question. How satisfied you are at work? Again, single item satisfaction determinant. Extremely satisfied is 1, is a spectrum 1 to 7. So extremely dissatisfied is 1. Extremely satisfied is 7. So we'll go with 1. Dissatisfied. Perfect. Glad. Again. Who would say 2? Who's level 2? From again, 7 is extremely satisfied with your kind of career at this point, or work, whatever you want to call it. So who will go with 3? 4? I'm going to come and work with you. Okay. 5? Okay. 6? Excellent. 7. Who's extremely satisfied? MashaAllah. What do you work? Where do you work? We'll come with both of you. When? That's why you are satisfied. You have a lot of application tomorrow. Exactly. So why I brought satisfaction, and satisfaction goes down, burnout goes up. So if you balance satisfaction and you own your own satisfaction and you maintain your satisfaction, then you prevent burnout for yourself. So now let's look at epidemiology of burnout. And I mean, again, being most of you oncology, working with oncology patient or any different, I mean, I'm emergency ICU. When I work with oncology patient in the ICU, usually it's at the end of their disease most of the time. So in ED, we see them. But I would say again, I'm not oncologist, but I have that sort of snapshot of them when they are acutely ill. They come to emergency department or when I see them at end of life in the ICU. So I do a lot of end of life with them and their family. We collaborate with oncology to address that. But yet, I would say my oncology experience about the community of oncologists is kind of as limited as my hospital. So I was surprised to see majority women, what Dr. Naji said, only 4 men in the room. And you would see now in a bit why I say that. So epidemiology of burnout among healthcare provider. So in US, they do a survey and they survey all, like many healthcare provider. So burnout rate is about 40%. So 2013, 39.8, 2015, 46, 2020, 43. So it's kind of around 40%. And that's across all specialty, all profession. Now, likely you know her, Atlal Abu Sanad. I don't know her personally, but seems to be very sort of well-regarded oncologist in Saudi. So she did this in 2020, just before COVID, but published 2021. So epidemiology burnout in healthcare provider oncologist. The survey was taken by men and women, but amazing prevalence among female oncologists, 70%. I'm not surprised with all what you deal with your patient. I can understand. Now, great, they did logistic regression on the answers, like those who are not burned out, what did they say that prevent burnout for them? So practicing a hobby, so having something else to do outside work, something that's non-clinical. So research won't be count as hobby. I mean, it could, but not really. And then enjoying interpersonal professional communication. So when you really build that sort of career network and you share challenges and tips how to overcome them, that actually helps to prevent burnout. Now, this is ED literature, so that's what I do every day. So Dr. Majid Salama there, educator, emergency from Saudi. So he did 2018 survey among emergency physicians in Saudi, 13.5 prevalence burnout. Another study in Saudi, 16% among emergency physicians in rural area of Saudi. Now, the study I sort of led in Mafraq Hospital just before COVID, just before we moved, was 2019, December. We did all physicians, about 300 physicians. We had a response rate of about 70%, 11% prevalence of burnout among all specialty. Now, we had 39 emergency physicians answering, 23% had burnout, and that's burnout. That's not the mild spectrum, that's burnout. Now, MBI, so Maslash, so MBI inventory, so it's kind of the famous validated burnout survey. And it has a healthcare provider. If you want to really test yourself, $20 online, you sign up, you do it, they'll send you a report about yourself. And they will tell you, they have 5 spectrum of burnout. They will tell you which one you are at. So if you really kind of the least one, then you are kind of safe or second. But if you are 3rd, 4th, or 5th, then you'll need to address it. Now, what drives burnout? You have the y-axis, and correct me if I'm wrong, and x-axis, right? So x this way, y this way, right? So still the same, did not change since school. Okay, so here I read it because it's kind of small. So driver burnout and engagement in physician, workload, job demand, efficiency and resources, meaning in work, culture and values, control and flexibility, social support, community at work, work-life integration. And then you have the x-axis, individual factor, work unit factors, organizational factors, national factors, right? Now, who read the 7 Habits of Highly Effective People? So I've read this about 2016. The main lesson that I've been teaching since then in this book. I mean, it's an amazing book. Probably I need to reread it. But then in the second or first chapter, he was talking about the sort of the circle of concern. So simply, there are factors under your control, and there are factors not under your control. And then there are factors of high priority or low priority. So where you should focus is high priority under my control. Could be high priority to me, but not under my control. If you focus there, you increase your stress, and then that will lead you to burnout eventually, right? So I would say here, if we take that principle and I focus under what's under my control, then you own your individual factor, work on those. I believe that we should, as healthcare leader, work on the system and organization factor. Unit factors still under individual control, because I speak to my share, I'll speak to my colleagues, and we can do something in our unit. But then at organization level, at system level, that's when we still raise our voice and we address it, but then it will take time to change. But doesn't mean that I'm going to ignore my individual responsibility, right? So impact of healthcare provider and burnout on patient, and it's one slide from AMA. Simply, each 1 point increase in burnout correlate with a 3 to 10% increase of physician-reported medical error. So if we are burned out, we're harming patient, even if we don't realize, we don't know. Now, humanitarian, I would put that aside. I mean, divorce and all kind of what will happen to the person as a second to burnout, but that's again your own individual responsibility. The financial part, use that to address with your manager. Most manager, I would say, focusing on the problem of today. So they want to fix the organization. They will ignore the human factor and the human who are building the organization. And likely they do that subconsciously. They don't mean to ignore us, right? But then what happens is, if you lose one physician, to replace that physician will cost you $500,000 to $1 million. So it's not easy. So you can use that to tell them, let's care about our employee so we don't waste money indirectly. Now, overcoming burnout, and that would be the end of the sort of like the tips I'll give you to sort of adapt some of them. Work-life integration. I don't advocate for work-life balance. You just can't. Wheel of life. 8, some wheel of life go 10 aspects of your life. I would say 8 or 10 doesn't matter. They're all the same. So there are 8 aspects in your life. You cannot balance them. One day I'll have an exam. So my career, my education will be priority. Then I still know I have 7 aspects in my life. Well, I have a plan. So I'm giving priority this year to my exam, my career, not ignoring everything 100%, but I'm not going to expect to be perfect. And I'll explain to my family and whoever I'm responsible to, right? Finish that exam, then prioritize the other aspect in your life. But you cannot ignore everything and just focus in career. What I always tell my residents when they don't pass their board exam, career is one of 8 items. If you fail your exam, doesn't mean you are a failure. It's as simple as I failed an exam. Let's plan how we pass next time. But you are a well-rounded human being. You have 7 other aspects. You have been doing great on some of them or maybe all of them. Now, this is my real life in 2011, 2015. So I was a doctor. And then if you look here, I was a volunteer physician. So all my free time went to volunteering left and right, teaching in conferences and then volunteering as sort of humanitarian, whatever. And then I was doing master quality healthcare management. I want to figure out how can we fix the healthcare system. Then I was practicing emergency medicine, ICU, built the residency program, took care of education, then took the responsibility of as chair of the program, plus being program director because it was thrown on me when I did not yet build the program well to hand it over. Then I was still in the Arab board as examiner, and then co-founded the Professional Society of Emergency Medicine in UAE and led the branch of Emirates Medical Association in Abu Dhabi. So you can imagine 24/7, my brain was just around career, right? Definitely don't try that. It would not work. I can tell you the end of the story. 2015, I hit burnout. Then I took seriously. I mean, how did I know? I mean, I knew I was tired. I knew that a year before kind of hitting burnout. I knew that when I finished my master that I'm not gonna, because my plan was to do 3 masters. So I said, okay, I'll take a year break, then I'll do the second master. Then someone comes to me, oh, we need you. We have this project as intensivist. You need to help. So I'm like, okay, let me think. I'm tired. I need to rest this year. I was planning to focus only in my work and build the program. So he goes, but we need you. And I can't say no, because if you need me to help the patient, I mean, that's me. So I'm not going to say no, right? So I ended up signing up to another master in my rest year. And that master was so condensed online and in person, where I went to Barcelona and do sort of training in organ donation transplant. And then by end of that master, that when I hit the burnout, I wake up in the morning in the middle of my 1 week ICU service. I just could not think, could not go to the hospital. My first ever sick leave day where I called in, I cannot come to work. I've never taken sick leave in my life. That when the alert went up, if I cannot do the most thing I love, kind of honestly to do, which is caring for my patient, that when I realized it's a problem, right? So then I started reading about burnout, figuring out how can I get out of it. I slept all the 2 weeks of my kind of off days. I recognized I was not sleeping. So I slept off, really kind of slept well. Hydration, and I started working out for the first time in my life. 10 minutes here, 5 minutes there, not much, but that did help, right? And then from there went to other hobbies. So hiking, mountain, exploring, like I try everything. I like it, I continue. I don't like it, then I go ahead. So this is my life wheel balance today. So, and you can see here, the areas of interest have been expanding. But then now I realize I was perfectionist, wanted something to be perfect. You cannot be perfect, right? But you need to sort of integrate. So today I'm here in the morning, I had an exam. I just told Ron, I'm not going to tell you, I'm not going to share what I study, but I study. So I have exams. So it's midterm exam. So I did my exam, then came here. I'm going to teach, going to go home, tomorrow flying to Jordan. So this is a crazy week. But then in Ramadan, I'm trying to just say sorry. Ramadan is my spiritual, my rest month where I'm going to fast, go to work, and just do nothing if I can, hopefully, inshallah. Then, now, last tool, I want you really to go home and do this. Ikigai, Japanese concept, 4 questions. You ask yourself, you answer them, would help you to identify your purpose of life today. I mean, our purpose can change, but I'll tell you my answers, and they did not change since I read about Ikigai a few years ago. What do you love? What the world need? What you can be paid for, what you are good at. So to help and add value, that's what I love. So if someone asks me to help, I would say yes before I say no or even think about no. What the world need, leaders, not titles, not managers. We need leaders, and you can lead every single task you do. As simple as, if I'm going to park my car, I'll lead that task and park in the correct space, not going to block the handicap, for example, or special needs sort of parking lot, right? So as simple as that, if you lead everything and you try to do your best as an individual in this world, the world definitely will be a better place. What I can be paid for, well, today is a clinician. Tomorrow is a different thing. Delivering result is what I'm good at. If I commit, I deliver. So now I learned with time, if I cannot deliver or I have doubt, then I'm not going to commit. And if I apologize, means my heart was not there. And this is something I did not love, so I'm not going to do it. So let's be clear from the beginning. So 3 books I would honestly advise you, if you like reading, read them. I mean, I love reading. So Peak Performance, evidence-based, based on two authors, one of them healthcare provider who went through burnout, and they simply focused their book around sort of high performer, most of them athlete, what make them perform well and don't go through burnout, and what might put you through the risk of burnout. Very easy read and nice tips. Ikigai is just explains that concept, very easy read as well. The 100-year life. We're gonna live long, whether you want it or not, inshallah. Honestly, you need to plan for that. When you're 95, when you're 100, I mean, you cannot retire when you're 60 and live 40 years after without a job. I mean, what are you going to do? Even if you save money, you're going to spend that money, right? 40 years is too long. That's another life. So you need to plan for that. So I personally, inshallah, I really pray for this. If I die early, you will feel sad for me. I want to live till 95. And if longer, 1 year or 2, maybe, but 95, but healthy, right? So you want to work as well to maintain your health. You don't want to live to 95 and not enjoying life, right? So I want to live 95 and enjoy life as much as I can. So that's honestly a book I would recommend you should read it, because we all going to live long. So you want to plan for your long life. So I'll close by saying, invest in your well-being, work on individual factors as you address organization and system factor, and spread the wisdom and support your colleagues. If you notice someone might be going through burnout, just share your tips with them. Some tips might work for you, might not work for me, but I always kind of like to ask people and hear from them. And then I try things. It works, then I'll adapt. It doesn't work, then I'll try something else. Now, Peter Rosen is the founder of emergency medicine, father of emergency medicine. He passed away at age 96, just 2 years ago. So I look up to kind of live a kind of a productive life like his life. So he said, nobody wake up this morning and decided to ruin your day. Do not get angry at your patient. Happiness is your choice. You want to be happy, you can be happy. Now, I'll close by saying the purpose of life is to live it, to taste it, experience it to uttermost, to reach out eagerly and without fear to the newer and richer experience. I mean, what if we do something wrong? Really, it's not the end of the world. So thank you so much, Rola. And thank you so much to everyone. And apologies if I was rushing, but I mean, 15 minutes, I was thinking, I mean, again, alhamdulillah. Thank you.
Dr. Aisha, thank you very much. I think this is the best closing for this session about wellness. We have a saying in Arabic is Bab al-Naggar Makhalla, which is like we are doctors, but we don't realize if we are sick or we are burned out. I think that's a very nice takeaway. Thank you, Doctora. Thank you. Dr. Gola, over to you, panel discussion. And if we have any questions online.
I just checked. There are no questions online, so probably we'll take some questions from the audience here. Yep, Dr. Hiba.
So my question is about the burning out. I believe that if you ask me today if I'm burnt out or not, I would answer no, I'm not. Maybe tomorrow in the morning or in the afternoon, I would answer yes. So, so how can we rely on the questionnaires and the statistics and how can we analyze the results as long as it's very, very changeable? It depends on a lot of things. I mean, the mood, the hydration, the hours of your sleep, and whether you have any pains in your life, in your body. So how come?
So the one item I shared is validated compared to the MBI detail. So the MBI detail takes about 15 minutes to fill. So they both are comparable. Now, when they ask you, they tell you if you have that feeling you mentioned once a week or twice a week or rarely, right? So that would give you some reflection. So I would say start with that one item question. Ask yourself, if you answer one with confidence, like in a whole month, I did not get that feeling that I'm burned out, I would say then you are good, in a good space, you're doing something right, okay? If you say, for example, you're number 2 or 3 or 4, then I would say, go online to MBI, take the 15-minute questionnaire. It's $20, which is affordable to all of us. They will give you a detailed report, and you'll know where you stand in the burnout spectrum. You might not be burned out, inshallah, la, yani. Like, and I think most of us pass through that phase one time or another, right? Laakin here depend again in the habit you have. Some of us grew up having hobbies and valuing kind of aspect of their life, and some of us did not. Yeah? But all depend about what you do and how you prioritize. I always felt to prioritize. Everything was important. When I learned to prioritize, I'm definitely in a better shape now. I mean, again, depend personality, perfectionism, الأشياء كلها. لكن the other thing, all physician, healthcare worker become perfectionist by default because you cannot accept something wrong with your patient. La? Exactly. Exactly. So we are devoted and we want to help the patient. Now, let alone you guys, oncology, with all the demand and hard conversation you have with your patient and going with them through their hard journey with the disease. So that's why reading 70% among oncology was not surprising. I mean, us emergency physician, when we have 20%, 17, 15, it's high because that's really kind of high, right? But for us, it's the shift work and all the stress with such an acute illness. But then 70% that need to be dissected and looked at, to be honest.
Another very important questions, and I think it's applicable to the 3 speakers of this session and probably to all the speakers, including those who did not speak as well. A comment from one of the attendees is a quick talk, quick question. Did you experience that many of the things that inspired you actually did not earn you income? So, and you did them? So the question is, I guess, how do you balance things that you like to do, but unfortunately did not or cannot get you the income? So that's a huge cause of burnout. So any comment on this? Aisha?
I would say that ikigai I shared at the end. So in the ikigai, one of the things, how you can earn money. So if I earn money to satisfy my needs, then doesn't mean every single thing I do should add to that money, right? So I have a job, I have a salary that satisfies my need. Then it would be your decision, your call. When you give, you have another meaning, you have another need that you're fulfilling other than money. So we said in the Ikigai, how you can make money, that's an important aspect. I want to fulfill that. So I fulfilled it. Now, other activity would give me another type of fulfillment. So I do volunteer. And when I volunteer, I don't get money for that. So I've been traveling to build emergency medicine in Africa. And that gives me a huge satisfaction and reward that I cannot compare to money. And it's part of my annual leave. But then I prioritize. So 1 week to Africa, the other 5 weeks is to me, to other activity I do in my life, right? So balancing between what you can give as volunteering or without kind of payment, and then making sure you have enough payments to satisfy your need. I mean, what might be satisfactory to me might not be satisfactory to someone else, right? Some other people want Bentley and other things. I kind of don't care that much.
Thank you. The last question, Dr. Rana.
Not the question. My name is Rana Bursi. I work for Dubai Health Authority in pathology department, not oncology. But we have very good exercise. If you have healthcare workers, nurses, scientists, whatever, it's the best way to predict burnout in your departments is like to do productivity. Okay, so nurses do productivity as per equity. In the lab, we do it as per benchmarking. We have a Q probes. Each area in the lab, in the hospital has its own way of productivity. So when we did the productivity, we predicted that we have burnout in this area because the productivity was 120%, which is huge. And then guess what happened? Is like one of our staff got MI and he is in 40s. So my advice for all of you, if you feel like your staff is going to be burnout, is like do productivity studies. Productivity studies is like capacity, occupancy of the work. Don't overload your staff, nurses, scientists, radiographers, or even pharmacists or clinicians, surgeons about it. So productivity study is the best way to predict burnout, and how to prevent it. This is your legacy.
We're going to get started, please, with session 3. And as I promised, it's going to be a wonderful session. And we're going to get started with learning about the journey of a breast surgeon living in UAE. So let me just introduce my colleague. And unfortunately, Dr. Huriya Kazem was supposed to be with us today, but she's now in London and she couldn't even join us virtually. However, you will see her talk. It's really pretty amazing and impressive. And Huriya is actually a UAE national and the country's first lady surgeon. Can you count now? Now we have our 3. Our triangle is complete. She attended medical school at the Royal College of Surgeons in Ireland and has a Master of Public Health from the University of Texas in epidemiology and disease control. She obtained a double fellowship in general surgery from the Royal College of Surgeons in England and Ireland before subspecializing in surgical oncology and breast surgery and reconstruction at the Royal Marsden Hospital in London. So please, she has a wonderful biography. Go back to the packages that we gave you and you can learn more about Huriya. So help me in welcoming Dr. Huriya Kazem.
And thank you everyone for having me give a talk today. I wanted to put 40 years of my life into 15 minutes for you, and here is my story. So I led a sheltered life that's typical of my culture here. My parents were the kind of parents that didn't bat an eyelid when I would say I'm never getting married or I'm never having kids. But the day I woke up and said that I didn't feel like going to school, the earth would literally go into a holding pattern until I came to my senses. Still, I was never allowed to talk to boys. I couldn't go over to a friend's house if they had brothers. And I went to an all-girls school. So clearly I wasn't trained from young to be comfortable in the presence of men, leave alone to infiltrate what I think is the last bastion of male domination, that is surgery. I started medical school in Dublin, actually wanting to specialize in infectious diseases because I loved all those flesh-eating bugs. And I was drawn to the idea of public health, of treating a community rather than an individual patient. But to specialize in ID, you first had to train in general medicine. And in medical school, I found medicine ward rounds really long, extremely dull, with too many discussions about split heart sounds and obscure neurological signs and whether a patient had bronchial breathing or not. And then halfway through medical school, hanging out in casualty one evening, a surgical registrar placed a scalpel in my hand. And that was it. Forget flesh-eating bugs. So I decided I wanted to be a surgeon, even though I had never, ever seen a female surgeon of any kind. On a ward round in my final year of medical school, a male surgeon asked a group of us what specialty we were thinking of heading for after graduation. And when I sheepishly mumbled surgery, his reply was, "You're very aggressive." And I thought, of course, if I'd been a guy, he would have said something like, "You're very ambitious." And surgery during medical school, I can honestly say, scared me. It was populated by large men doing big things to lame but grateful patients. And these surgeons flitted mostly between being moderately irritated to excessively angry. And I remember assisting one such surgeon in the OR one day, and he grabbed all the instruments on the field that OCD me had been neatly arranging in little rows and flung them across the OR, cursing and accusing me of being like his wife, who presumably liked neatening up his mess. And I had all manner of things flung at me, most notably having to duck to avoid being slapped in the face by a flying spleen. So did I really want to emulate these men? I returned to Dubai as an intern and noticed a great need for a female surgeon, as many general surgery patients with issues such as hemorrhoids and anal fissures would only let me examine them. The rest of the all-male team will be on the other side of the curtain, and I would have to describe my clinical findings to my consultant. And then he would say something like, "So does she need surgery?" And I'm like, "I have no idea, I'm just the intern." And this is also the time when I saw women with advanced cases of breast cancer, the likes of which, honestly, in textbooks of years gone by, it was not unusual to see cases of carcinoma and cuirass. And it truly horrified me that a woman would leave her disease to such an advanced state. And it was these women, and in most cases their sad demise, that inspired me to specialize not just in surgery, but in the surgical treatment of breast cancer. So I headed to the UK and started my surgical postings. This was the most horrendous time of my life. Hours were long, studying was extensive, and if that wasn't bad enough, I'd come home to Dubai on holiday and had to endure all my aunties who were looking for eligible men for me to marry, saying, "You still studying, honey?" Like I was so stupid. Everybody goes away and would come back in 3 or 4 years with a degree, and I was 10 years out there still trying to do what I do. Anyway, the day I got my fellowship, my final fellowship in general surgery, my fiance actually cried with relief that psycho woman would be gone and hopefully his normal fiance would return. I didn't cry. I did what all women do in the face of adversity. I washed my hair. And I was on call that night, of course. I walked into the doctor's common room at the hospital and announced with pride that I'd passed the final fellowship exam. In the UK, when a male doctor gets his fellowship, his title changes from doctor to Mr., but these guys didn't know what my title would be. And that night, my male colleagues handed me a beautifully wrapped gift box with a note that said, "You'll be needing these now." And it was a box full of men's underwear. So during my time in the UK, every time I was shortlisted for a surgical job, I would scan the waiting room and know that I had to go in there to that interview and be better than the British guys, the foreign guys, the British girls. Basically, I had to go in there and be the best I could if I wanted the job. My first day as a registrar, arriving on the surgical ward at the Royal Marsden in London, I was met by one of the surgeons from the appointing committee who grabbed me by the shoulders and said, "You're in the wrong place. The gynecologists are operating in the basement." And at another job interview, one of the consultants asked, "Don't you think you should be getting on with the business of marriage and having babies?" I've had some patients, even female ones, who have requested to see a male doctor, or worse, a real doctor, instead of me. And I gave up wearing a white coat on rounds as I was regularly mistaken for the dietitian. When I think about these events now, they just amuse me. I don't know, I'm sure many of the difficulties I faced were not peculiar to women, and that guys got told at interviews that they should be off getting married and having babies. I did become conscious, though, of this uncontrollable parameter in my life of being a woman, and finding to my dismay that sexism was alive and well in surgery. So yes, I became the brunt of much teasing and leg pulling, some of which would be considered unacceptable in today's woke culture, but most incidents were petty, though important, because taken together, they constituted formidable barriers. Sometimes, if you look around the portraits that hang in the Royal Colleges of Surgeons, or look at any lecture series on a surgical topic, apart from breast, women are consistently underrepresented. When I graduated from medical school in the late 80s, only 20% of the graduating class were women. Nowadays, it's more like 50% or more, which is due to a deliberate evening out of the admission policies of medical schools around the world. When I got my fellowship in surgery 30 years ago exactly, women consultants in surgical specialties accounted for just over 10% of the total in the United States, about 2 or 3% in the UK and Ireland, and 0% in the UAE. A recent audit in Ireland shows these numbers to be only slightly better now. From 50% of medical school classes being women, this drops to 34% of surgical trainees and 7% of surgical consultants. So it went from 2% to 7% in 30 years. I guess the trajectory is in the right direction, but honestly, we should have reached parity a long time ago, and shouldn't medicine as a profession be leading the way in gender equity and diversity and inclusivity? The fact that I did not walk into those interview rooms feeling that all of us were on an even platform is a sign of discrimination for me, based on both gender and ethnicity. These differences were often framed as individual failures. I was told to self-advocate, to be a better negotiator, and even to not have kids if I wanted to succeed in surgery. But of course, it wasn't about me being a poor negotiator. Anyway, I've completely digressed. I got my fellowship in surgery and subspecialized in surgical oncology. I arranged a visiting fellowship at MD Anderson and had a 3 or 4 month gap in between, so worked for free in the Caribbean doing general surgery just to see if I missed it. And I saw great pathology there and did a lot, but I knew then I just wanted to be a breast surgeon. Finally, I returned to Dubai in the late 90s, now a consultant in breast surgery. And even at that time, breast cancer was never openly talked about in our community. You would never dare say the word cancer, because if you said it, you would get it. Our Department of Health didn't even like the word breast. In Arabic, on my medical license, they use the Arabic word for chest, sadr. And of course, there is such a thing as a chest surgeon, which I was not. As a medical student, I'd helped an Irish surgeon make some educational videos on breast self-examination, and he kindly mailed me a box of these videos to Dubai, all of which was confiscated by the Ministry of Interior as pornography. There were days that I would have no patients, or maybe 1 or 2 patients, as historically women with breast problems here would go to their gynecologist. But gradually the idea of a breast specialist came into people's consciousness. And at that time, I also had to become a good breast radiologist and a breast pathologist, as we had none of those when I started out. And then I was ready to start a family. And not surprisingly, university, women surgeons marry later than male surgeons. I actually got married at the ripe old age of 39 after a 9-year engagement, and had my first child at the age of 41, with all the associated issues of being an elderly prima gravida. That's a big sacrifice, but honestly, I don't know if I could have done surgical training and parenting at the same time. So now I'm blessed to be starting a family, but I couldn't find any part-time work, not in the private sector, not in the government sector. As far as they were concerned, you were either working or you weren't. And then there was, maternity leave, abysmal, 6 weeks of paid leave. My second child was a 29-weeker who ended up in NICU for 4.5 months. I was a primary breadwinner at the time with a preemie on NICU and a toddler at home. So I asked my employer for flexible hours and was told that maybe surgery wasn't for me. I was literally on a high dependency ward for a placenta abruption, and they were calling me to cancel my contract. But after all is said and done, I love being a breast surgeon because it's more than just operating on the breast. There is surgery, of course, which now includes oncoplastic surgery. But when I did general surgery, you fix a hernia and the patient is off. In breast surgery, you follow your patients for years, getting to know the entire family. And I've been doing this long enough that I now take care of patients' daughters. So there's a bit of family medicine there. And most women with breast complaints think they're all dying of cancer. So I do a lot of counseling. It's also a very academic field. As a surgeon, I must keep up with the rapidly changing medical treatment for breast cancer. So as a new consultant, I found that there were several anxiety-induced waiting periods. Patients had to wait weeks to see me. Then they would wait for an appointment to get their scans and mammograms. Then they would wait to get those results. And then if they needed a biopsy, they had to wait again to see me again, and then wait for the results of those. And I saw the anxiety build, and I knew I could do it better with a more patient-centered practice. So in 2006, I started the Well Woman Clinic, which is staffed completely by women, for women and all their healthcare needs. It's a friendly, non-clinical center where patients are triaged so that the most urgent are seen as soon as possible. And we can pretty much give a diagnosis of a new lump in 24 hours. Apart from my work as a breast surgeon, though, I had to raise the national consciousness about this disease. So I started a purposeful awareness and education program, which I ran in schools and colleges and ladies' clubs and in the workplace. We produced award-winning educational videos in several regional languages for free distribution. These are videos about the breast without actually showing a breast. And to further address some of our local issues, in 2002, I founded a charity called Breast Friends, which offers support for patients and their families by removing such barriers as limited or no health insurance, lack of transportation, child care, and language and cultural differences. We run a support group for breast cancer patients that's in its 18th year. And 18 months ago, together with the Al Jalila Foundation, we opened the only cancer drop-in center in the Gulf region, the Majlis Al Amal. It is a safe place where women with any type of cancer can meet, to do a class, to learn something new, relax, and sometimes we just eat chocolate and talk. So in a really roundabout way, I've come back to my public health roots. And paradoxically, breast cancer has its inspirational side. I now don't see as many of those advanced cases that I saw as an intern. This grassroots fight has taught me that education and good medical care can make a difference. And to complete the circle, Breast Friends, together with the Al Jalila Foundation, is working on locally based research into the epidemiology of breast cancer in our young women. So I'll end with a question for myself. I asked myself, would I do it again? Would I do it over? I'm truly blessed to have had the family I had who put so much importance on education. And it's been a privilege to take care of women at their most vulnerable. I don't think I would have done anything differently. I trained at a great institution. I picked a specialty that I find endlessly fascinating. And in a relatively short period of time, I've seen positive change. Alhamdulillah. Thank you.
Good evening, everyone. That was a great speech, inspirational from Dr. Huriya Kadam, which I had the privilege to meet. We actually graduated from the same College of Surgeons, but she was a few years ahead of me. So with that, let me introduce to you our second speaker, Dr. Supriya Kulkarni. She is the Divisional Head of Breast Imaging and Associate Professor, Department of Medical Imaging at the University of Toronto. Her clinical engagement is at University Health Network, Mount Sinai Hospital, and the Women's College Hospital. And she had an over 20 years experience in subspecialty practice in breast imaging. She is also the head of Breast Imaging Services, Medical Imaging Department, Health Sciences, and North Sudbury. Dr. Kulkarni's special focus is on teaching and education internationally. So she will be giving her speech virtually. And with that, and her talk is about the power and influence of giving back. So let's all welcome her, and we can start. Thank you.
Greetings, everyone. Thank you for being here and attending this session. And I'm also very thankful to the organizers, specifically to Dr. Rola Shaheen, for inviting me to give this presentation. The topic that I have been assigned today is power and influence of giving back. And I've been asked to speak a little bit about my own experiences and my own journey through leadership. I have no disclosures. So what is the difference between power and influence? I spent some time thinking about this. Power is the capacity to get others to act based on positional authority that is exercised over others, often leading to resentment. So there is a negative connotation to the use of power, as we can see. In different walks of life, we see the effect of power in political scenarios, academic institutions, banking, any sector that you may interact with. Influence, on the other hand, is the ability to modify how a person develops, how a person behaves or thinks based on relationships and persuasion, often leading to respect. So it has a more positive connotation as compared to power. Now, of course, we do realize that power can be good or bad, influence can be good or bad also. When you think of these two terms, they are very strongly tied with leadership. Leaders are always perceived as either being powerful or being influential or even both. And at the end of the day, leadership success is measured by what the leader leaves behind. So it's all about legacy. What does a leader leave behind him? How does he train his people or her people? And so legacy is a very important component of any leadership that we see across the world. So this is where my journey starts. This is my small family in India. I grew up in India. These are my parents, and you can see my younger brother on my mother's lap. This is my sister sitting on my dad's lap. And as always, I'm in the center of everything. This is me being 7 years old. So I grew up in a small town called Pune, which is now no longer a small town. It's located in the state of Maharashtra, close to Mumbai or Bombay, which you may have heard of. And by 1996-97, I had finished my radiology training. My postgraduate training was complete. I was working as a radiologist, and I was looking for some opportunity. I wanted to do something different. I wanted further educational experiences. I traveled to different places in India at academic institutions, meeting academic radiologists, and that inspired me further into looking into different options of what else could I do to improve my my career or my abilities as a radiologist. So this is the hospital where I was working in Pune. It's called King Edward Memorial Hospital. It's still there, much larger than what it was when I was working there. And here I was under the mentorship of a very unique individual whose name is Dr. Shetty. And Dr. Shetty was a radiologist with a vision. He was a very different kind of a person. He still to this date is this great visionary. And he always spoke about leaving behind a legacy. It's not just how good you are or how well you report, but it's also about training, creating opportunities, and leaving a legacy. So his vision really inspired me a lot, and he continued to provide encouragement to me to looking into options of where I could further go. And he introduced me to this one person. Her name is Archana, and she helped me to apply for a fellowship in Australia. This was in 1996. I had no access to internet, no computer at home, and the application process was such a huge ordeal because every single document had to be faxed, and we didn't have a fax machine. It had to be sent by a public fax machine. Eventually, my dad bought me a computer at home, and I could communicate with emails. And at the end of it all, by the end of about 1998, at sometime around that time, I got an invitation to present myself for a self-funded observership. Now, growing up in a modest household that really didn't lack anything, I still hesitated to jump at the opportunity that required self-funding. I did have some money of my own, and my dad was willing to support me, but nevertheless, it was a difficult decision. I never heard of student loans before. I only heard about student loans when I arrived in Canada. And so I was struggling to make this decision. What should I do? Should I give up this opportunity? Where should I go? And then one day, Dr. Shetty came to the hospital and he brought me a tiny little newspaper clipping, which was an advertisement of an organization who provided scholarships to girls who wanted to go for higher education, either in India or abroad. And that was my first discovery of this organization called the Leela Poonawalla Foundation, which was giving out these scholarships. So this is a picture of Mrs. Poonawalla, Mrs. Leela Poonawalla herself, a very huge person, Indian industrialist, very famous philanthropist, humanitarian. She used to be the chairperson of big companies such as Alfa Laval, Tetra Pak, and she was an engineer herself, coming from a very meager background, shooting into this huge position, and internationally and nationally well known. So she had a lot of influence and power, and she and her husband, Mr. Firoz Poonawalla, founded this particular organization because they wanted to leave behind a legacy. And so this is how the Leela Poonawalla Foundation was formed in the year 1995. And since then, their work of leading Indian ladies ahead, which is like Leela, stands for Leela, has transformed the lives of 14,000 plus girls, touched multiple families, engaged in multiple skill building training programs for their fellows, and provide scholarships across the board for young girls and girls who want to study further and require support across different cities in India. They still continue to do this work. Here's an example of a picture showing support given to a girls who can't even support their primary school education. The organization partners with multiple big companies, such as this is an example of their partnership with IKEA. And this is the CEO of IKEA who visited India, and you can see him presenting a scholarship to this young girl for her school education. So Mrs. Poonawalla was highly influential in developing these huge contacts while she was working in the corporate world. And she used all her power and influence to put so much resources into this foundation that is helping all these girls to move ahead. And so I ended up becoming one of these Neela fellows at that time. And when I met Mrs. Poonawalla at that time, she said, Supriya, you don't really need a scholarship. You can do it yourself. You can walk into any bank, get a loan at the level of education that you already have. But we are going to give you this scholarship because it will help you to make that leap, that decision that you can do it. You can go where you want and you can be what you want. And so they gave me and awarded me a scholarship of 25,000 rupees, which today is less than 500 Canadian dollars. But at that time, it gave me that impetus that yes, I can fly. And they helped me turn my dream into a reality. This happened in 1998. In 1999, I left India and I went to Melbourne, Australia at the Royal Children's Hospital. This was a mind-blowing experience where the world just opened up for me. I met so many different people from different countries, fellows like myself, made tremendous friendships, and which only grew over the past 25 years. From here, I applied for another fellowship in Canada at the University of Toronto. I had never dreamed ever of even going to Canada. And I traveled all the way to North America for an interview and I got selected. In 2000, I arrived in Canada at a University of Toronto fellowship, which was the most unique experience in my life and gave me tremendous growth in terms of my personal life and career. These are the places which I work now in Toronto. This is the Princess Margaret Hospital. The arrow there is pointing to where my office is located. I was hired here after 1 year of fellowship, and it's been just go, go, go. There has never been any turning back. This is the Princess Margaret Hospital, which is one of the largest cancer centers in Canada. It is the top 5 cancer research centers in the world, and it has a tremendous clinical and research footprint across cancer care. This is Mount Sinai Hospital, another hospital where I work at, and this is the Women's College Hospital, all of them under the umbrella of the University of Toronto. After 23 years today, I am an associate professor at the University of Toronto. I'm the divisional head of the breast division at the University of Toronto, which is the largest breast division in Canada. It is the largest teaching program for residents, women's imaging fellowships, and breast imaging fellowship programs. Over the past 23 years, I have continued the work of creating and passing on the legacy by training and mentoring over 50 postgraduate trainees from different parts of the globe, some of them becoming leaders on their own accord in their own areas and regions and countries, continuing to train and create new leaders such as themselves. For leaving behind legacy, you need to do what you do the best. For me, education and teaching was my strength. And so I decided to use that to further education in breast cancer care. I continue to travel, and I have traveled extensively to lecture and contribute to other programs in different parts of the world, such as India, Singapore, Canada, Middle East, visited Kuwait multiple times upon the invitation of the government, and lectured through multiple channels, including online channels. I have had the opportunity to lead multiple high-profile successful conferences across the world and have delivered over 200 lectures, published books, and book chapters. I always have made it a point to give back from where I came, and this is the work I continue to do in India, visiting different centers. The one here demonstrates where I visited CMC Vellore, a huge academic center in South India. This is me presenting in Chennai at one of their conferences with the Apollo Cancer Center, and multiple other conferences that I have presented in Goa and other parts of India with my friends. And not missing any opportunity to meet with my ex-fellows and colleagues and friends and to catch up and keep in touch with respect to breast imaging and personal relationships. These are just few images of different locations that I have presented on different topics of breast cancer diagnosis, screening, and management. And here is a picture from last year at the RSNA, which is one of our biggest conferences, where I saw my book, Breast Imaging Essentials, being displayed at the Springer booth, and it was being sold there. It was a great honor to just see that book there in person after a long time after the pandemic. I have received numerous awards, which is a testament to my dedication to my mission of education and improving the care of breast cancer patients. Most notably is the Whiteman Beres Academy Award, which was presented to me for excellence in postgraduate education. This was a unique award that was given by the Princess Margaret Hospital, called the Outstanding Contribution to Cancer Education Award, which demonstrated appreciation for not just internally conducting educational programs, but globally across the world. The Indian Association of Radiology also awarded me a President Appreciation Award for my contribution to Indian radiology. More importantly, for being the section editor for breast imaging section for a comprehensive book on clinical radiology, which is will be published shortly. And this is the award that I received last year, and this really ties down the whole theme. It really completes my story. This was an Excellence in Mentorship Award that was presented to me last year for the year 2021 and 22, which basically validates the time and effort spent in teaching, educating, traveling, mentoring so many young radiologists, trainees across different disciplines, breast surgical oncology trainees, not just breast imaging and radiology trainees. So this was a huge honor to receive it from the University of Toronto, and it really made me feel very validated, and my journey kind of came to a full circle. I also spend a lot of time trying to balance my personal life with my life of teaching and clinical excellence. It's always hard to find a balance, but I'm really grateful to my husband and my son who continue to support me in this huge endeavor. We do travel a lot and try to spend time creating new experiences, just I did with my parents. So to summarize, there was a seed of determination, there was a seed of potential, which people around me saw. From time to time, different mentors, they came and they watered the seed. It allowed the seed to germinate, grow, and become a full-blown tree. This tree today is able to support other seeds, other plants growing underneath, making them also robust and strong trees. I learned a lot from my mentors, my teachers, my well-wishers, my spiritual guides. From their examples, I learned important qualities which makes one a good leader. It is important to understand that success doesn't just mean being the best at something, but doing your best, giving it your best shot and doing things with the right intent. If we do the
Oops. Maybe another technical difficulty, but thank you so much, Supriya. Very inspiring, and I'm not surprised. And I'm very honored to say that actually Supriya had taught me breast imaging when I was in the residency program at University of Toronto. Amazing and wonderful teacher and colleague, always ready to answer questions and give you time and listen. Okay, moving on for the next speaker. I hope she can come a little bit closer. She's very close to my heart, a wonderful friend, Dr. Alex Ekanomokos. And Alex is a South African board-certified dedicated breast radiologist with more than 18 years of successful experience in breast imaging and radiology management. Alex, who's Greek-German, was born in South Africa, where she completed all her medical education and entered private practice before coming to establish the first dedicated breast imaging service in Dubai in 2008 with the MedClinic Group. And I would have to say, Alex probably was the first breast radiologist that I met, and I love the quality that she's doing. She's actually a strong believer in imaging quality and a one-stop shop, and we shared that passion, and we stayed connected and very close since that time. Thank you for helping me welcome Alex. Alex is actually going to tell us how she can give us 15 minutes.
I think I know Rola longer than the family, probably for this point of view.
True. And thank you so much. You're going to teach us something today, Alex.
Thank you to all of you for still being here at 8:10 on Thursday night. Firstly, I want to say I'm talking about life-work balance.
But we're having fun.
Secondly, I'm following after two amazing speakers, and I feel like a sham talking about a life-work balance when all they've been doing is talking about the amazing work. Okay, but we have life to live. Okay, that is why we're here. So I'm coming here to speak to you about this, and when Rola asked me to talk about it, I was like, sure, why do you want me to talk about it? Just to give you a brief overview, my husband's a cardiologist. He was definitely wanted in the UAE, and I was the ball and chain. And when they asked me what I did, I said breast radiology, and they went, do you do anything else? And I went, well, no, just breast radiology. And they said, look, you can come up, we can give you a part-time job. And probably that's why I'm talking to you about this, because I came here to work part-time and I have never worked harder in my life. Anybody who does part-time, I take my hat off to you, because you will work full-time for less salary. I honestly really feel firstly, I think women should have part-time jobs, because I do think that we have the right to be able to sort that out. But you will work hard, and you will work very hard, and you will work as hard as your full-time employee, as your full-time colleagues. There's no question about it. So, bitchman session over. Okay. Work, life, work. I looked at your title and I thought, why did you say life in front? It should have been work first. Okay. It's always a work-life balance we talk about. And so when we look at this, it's the balance. It's work, career, business, responsibility, good performance. It's coupled with ego. It's coupled with all the things that make us feel like we're powerful. We know what we're doing. And then the good part, life, health, family, friends, happiness. But it's interesting, Sheryl Sandberg actually said, framing the issue of work-life balance as if the two are dramatically opposed practically ensures work is going to lose out. Okay, whoever is going to choose work over life. Okay, Jack Welch, on the other hand, who is the chairman, or was the chairman of GE from 1981 to 2001, said there's no such thing as work life. We heard that earlier. There's no such thing as work-life balance. There are work-life choices, and you make them, and these have consequences. And that is the truth. We heard that earlier from Dr. Asha as well. There's no such thing as a work-life balance. But there's one word on this slide that's so important. Happiness. Yeah. Happiness needs to be in the middle of this slide, okay? Happiness is great in work, and it's going to be great in life. And that's what we have to aim for, happiness. What's the ideal life balance? If you look at anything, it'll tell you that the rule of 8. 8, 8, 8. 8 hours of good sleep. I want to know anybody who does that. 8 hours of honest hard work. I'm telling you, I think we will do a lot more than that. And then 8 hours on the 3 F's, the 3 H's, and the 3 S's. Family, friends, faith, health, hygiene, hobby, soul, service, smile, okay? Good luck on that too. Usually you will find that you're compromising on one of those. Remember that work and life coexist. And this was from Melissa Stegenis, who is an author. And she said, wellness at work follows you home and vice versa. The same goes when you're not well, if you're not fueled, if you're not fulfilled. Work and life are not opposing forces to balance. They go hand in hand. They should be like a good marriage. And they're intertwined, and they're different elements of the same thing, you. Okay. So I had burnout. Absolutely. I'm telling you, everybody in this room has had it. If you haven't had it, you'll get it if you're really excited about your job. Okay. The burnout killed me. I came here part-time. I thought I was going to be a great mom to my children. Well, I never saw them. I worked like a dog at the hospital. I never saw life. I used to see sunrise on pictures because I'd leave before sunrise and I would be home before, long after dark. My husband was working as well. Thank God I had him, and thank goodness he was able to help me a little bit of the time. But honestly, if somebody had walked into the room and said to me, "How are you, Alex?" I'd cry. I would cry my heart out. If somebody just showed me a little bit of gentleness, I was finished. That's burnout, emotional wreck. That's what I was. I wasn't doing anything good for the management. I was doing zero good for my patients, and I certainly wasn't good to myself. And where does that leave you? Nowhere. So step back. That's my mnemonic. That's what I'm here to teach you. Take a step back. Okay. Any balance in life requires work. Don't berate yourself. Don't think that you're doing it badly. It's a cycle. It's not an achievement. So my step back mnemonic goes, stop, think and reflect, evaluate your emotional status, prioritize or reprioritize, build a plan, think of some alternatives, change it and implement it. The most important part, and keep moving. Sometimes you have to take a step or a half step back to take 2 steps forward. And that's so important. So let me go into this a bit more. Stop, pause, and think. ST. I told you I had a rock bottom moment. And I will tell you that most times we will sit and talk about work-life balance and no one's going to take you seriously until you hit that rock bottom moment and you realize that you are doing yourself no good. You actually will probably land in hospital. You will be depressed. You will either have a breakdown, a mental breakdown, or you will realize that you're starting to head towards a divorce because your spouse doesn't want to be around you any longer. Your children don't really want to see you anymore because you don't spend time with them. Or you start having issues at work. So it's at this time that I actually realized that work was taking the biggest toll on me and my life was suffering. And that was an emotional, physical aspect, not just to me, but to my family as well. So it made me think, what causes stress? What causes unbalance and dissatisfaction? And how are they actually making me engage into my work and do my job properly? How are they impacting my personal life? What was I prioritizing? What was I sacrificing? And what was getting lost in all of this? I wanted to be superwoman. I could do it all. I could be the great mom. I could be the brilliant doctor. I could be the great radiologist. I could be the business manager. I could do it all. Actually, I was doing nothing of it really well. And only after I'd taken that mental pause and actually acknowledged all the problems that I had, could I actually see it for a little bit better so that I was able to tackle it. E, S-T-E, emotions. I just was crying all the time. I couldn't even recognize it at the time that how upset I actually was. So you need an increased awareness of your situation to make you realize what it makes you feel. Are you feeling energized by the work that you do? We're all energized here tonight. Are we energized? Are we relaxed? Are we smiling? Do we actually feel like we're giving back? Or are we angry, resentful, depressed, don't want to go to work, feeling stressed. So this awareness of your emotional state is really, really important because it makes you determine the change that you want to do in your work and in your life. The P, STEP. By increasing both the cognitive and the emotional awareness, now you can find the tools that you need to be able to put things into perspective and determine how you're going to prioritize. What are you going to sacrifice? We heard just now from one of our speakers, it's fine. The whole year was taken. She told her family she was not going to be with her family for that year. I can tell you that wasn't going to work with mine. Okay, so these are compromises that you have to work out. Okay. Can you sacrifice being away from your family and for how long? Or can you sacrifice not being a hard worker and for how long? Will you lose your job? What are the options? Is someone else going to take over? And if you're prioritizing work over family, why is it so important that you have to do that? Okay. Is it necessary? Are there other options that are, can it really be that you can try and think of something else to try and change it? And what regrets do you have? My biggest regret was that I never went to see my kids in school. I cannot take that time back. So now I've got young girls working with me and I'll give them the time off to go. Let them go early and drop their kids off at school. What a beautiful time to be together with your children. The option to go and see them play sports or to go and honestly, kids appreciate that. Somebody said a little bit earlier, it's about what you remember, how you felt. Okay, and children remember how they felt. Now it's time to build a plan. Okay, and Dr. Asha was talking earlier about the 8 steps. It's too complicated for me. I like 5. I've got 5 fingers. Okay, so I used to think, right, family, finances, health, should actually be the other way around, health and then finances. Okay, but family, finances, health. I love travel. Oh, and work. Okay, those are the important things. How am I going to prioritize them? And so I actually had to think, what was important for me? How was I going to end up looking after my life, making me feel good about me so that I could then make my patients feel good about themselves and have my clinicians and my referrers feel good about sending cases back to me. Not that I would be a shell and just churn out the work. And so before jumping into solutions, you have to first reflect on the aspects of your work and life that you can be different, that you can do differently. And so I told you about the 5 fingers. Ascribe a score of 10 to each of your fingers and then classify it. Is it 2 out of 10? Is it 10 out of 10? Is it 7 out of 10? And what do you want that happiness factor to be? Because if you can work out your happiness factor, you can prioritize your life and then choose. I mean, I saw that beautiful wheel of life. It looked really elegant. And I cannot say that I would have been able to follow that because I was broken. And so the only way to do it then is to really look at the skeleton of what you can try and choose and decide what's important for you. Are there components of your job that you want to see changed? Of course, all of us would like to know that we're respected more at work, that we can earn more at work, that we've got more time to do the things that we want to do. It's not going to come with you just stamping your foot and hoping for it. There are things that you're going to have to be able to change. How much time would you like to spend with your family and hobbies? Earlier, we were talking about how much you get paid for doing your hobbies. I love jewelry. I do jewelry design and I make my own jewelry. I don't get paid for it. I promise you I spend, okay? I love painting, but it is the absolute joy that I have to give me emotional relief from the work that we do, which takes so much from us, okay? So the most important thing I realized was that I got happiness out of devoting my time to people who were high quality, who gave energy back to me as opposed to took my energy, and to activities that helped me. Exercise, very important, okay? Painting, jewelry making. And so this Eisenhower matrix, and if you haven't heard about it, it's really a brilliant little tool. We heard earlier about Ikigai, and I thought about putting that in here, and it's a bit complicated, again, because Japanese words, but still. The idea is, whatever's in your life, you have to decide what is going to be your passion. And these little boxes of this Eisenhower matrix, I applied to work and I applied to life. And when I applied it to work, it was so easy for me to say, okay, it's important and urgent. I've got to do it now. It's not important and it's not urgent. The answer is no. And that no, I took a long time to learn. Jeez, I took a long time to learn it. I'm such a yes person. Yes, I can do it. Yes, yes. Pile it on, pile it on. No. There's the box. Absolutely no. Delete it, eliminate it. It's not important. And then you can decide, is it important? And if it's important, is it urgent? And if it's not urgent, then you can decide when you're going to do it. That's the important thing. But if it is not important and still urgent, you don't have to do it. Give it to somebody else. Okay. So now you can whittle down the important things that you want to be able to take care of. And I promise you this works. You've just got to be strict with yourself and put that into work, and you put that into life. Husband and children, important and urgent, mostly. All right. Friends who are negative energy, who don't give you anything back, delete, eliminate. Harsh, but true. Okay. And that has been the most rewarding thing that I've learned, the power of no. Delete and eliminate. Change it. All very easy to talk about it. Now put it into practice. We are creatures of habit. We fall back into poor routines. And so I told you, this is a cycle. It sounds all wonderful. You put it into practice, 2 or 3 months, and then the bad habits creep in again and you start doing stuff again. We'll see a patient who is a friend who suddenly gets cancer, and it's such a wake-up call. I am not going to do this. I'm going to be very good. I'm going to start all over again. And we start again. It's a cycle. That is what we have to remember. So in order to effect the change, I decided there were 2 ways one would look at it. One is where people obviously see that you have changed. How do you obviously see that you've changed? I'm not going to work like this anymore. I'd like to apply for a different position. I'd like to be really part-time. I'd like to only do perhaps compressed work weeks. So currently now I work 4 days a week, but I work up to 12 hours. So it's fine because I don't mind doing that so long as I can get my maybe Thursday, Friday, Saturday off, or my Friday, Saturday, Sunday off, or I can try and accommodate in a different way. It makes me feel better that when I'm actually devoted to work, I'm devoted fully to it and I'm getting joy out of it. But when I'm not at work, that's it. Okay, my phone's working, but I'm not at work, sort of thing. So the public side is where people can see that you've made big changes. If possible, you choose your different work hours. You don't work on evenings. You won't work on public holidays, on the weekends. You can turn down travel requests or any new projects. You won't win yourself any friends, I can assure you. But you at least are looking after yourself. Okay. The private part is a little bit harder to achieve because you've got to celebrate yourself. And again, the last person that you celebrate is yourself under circumstances like this. So it's really, really important to remember the beauty of no politely. Okay. Most importantly, don't bite off more than you can chew. And I think the bottom line is we always think that we are so much more capable. And we can really do a lot. But do we do it well? Do we do it effectively? And the answer is no. So finally, and this I think is the most important thing for me, never continue in a job that you are not happy with. If you don't enjoy it and if you're not happy, you'll never do it well. You will never like yourself and you will never have inner peace. If you have all those good things, inner peace, happiness, you are going to end up knowing, and you've got good physical health, you will always have more success than you ever could have imagined because you've got the joy going from work to your home life and back again. And it's a beautiful environment. So Albert Einstein was quoted as saying that life is like a bicycle. The only way you're going to achieve balance is by moving forward. You've got to keep moving. And I saw this comic, The Cycles of Life, in a bicycle magazine, and I just think it's brilliant. The bikes are always going in the same direction, but the type of bike that you have is different, okay? And so, but we're always moving, we're keeping going, because if you don't do that, you will stagnate. So we've always got to fix ourselves, work on ourselves somehow to try this balance work, which in all honesty, as I said, after those 2 last speakers, I felt like a fraud coming up here and discussing this. But no doubt, if you look after yourself, you will always go an extra mile and manage to achieve a lot more. So I hope that somehow some little words of wisdom have come from this year. If my little breakdown helped, this is the way it's achieved, and I hope it works. Thanks very much.
Thank you so much, Alex. Again, I'm so privileged to have her as my friend. And each time I call her when I'm down, you can tell why I feel good after I talk to her. Even when she's down, she puts you up. Well, thank you again. And I just want to hand you this because I know we're coming to the end of the session.
Thank you, darling.
Okay. Can we have one picture? And then Thank you very much. And now we're coming to the last session of, the last talk of this session, because unfortunately, Ms. Nisreen Qatamish cannot make it today. She had an urgent work commitment. So we will move to Dr. Lamis Abu Hleqa. Lamis is going to talk to us about bring it all together, empowering women for peak performance. And just to give you a little bit about Lamis. You can talk about yourself, but I'm very happy to read your biography. It's very interesting. Lamis is a distinguished public health expert. She's a physician and artist with over 15 years of experience in the field of medicine and public health. She graduated from the Royal College of Surgeons and holds an executive master's degree in healthcare administration from Zaid University. Dr. Abu Hleqa, she's also an ICF certified executive coach and has received ACC and ORSC training. Maybe you can tell us about it, okay? Well, welcome, Lamis, and please, this is your last session. Bring it all together.
Thank you, Rola. And I want to give you all a clap for staying until the last session. So please. You deserve this, and I'm sure you're enjoying it. I'm enjoying it so much. And as Rola said, we're wrapping everything here in this session. So you're going to see maybe some repetitive slides, but because it's all about wellness. So as Rola said, I'm a doctor. I work in public health. And I also took the chance because I love, like you, self-development, Tanya. So I joined coaching. I'm an executive coach and I'm a relationship coach. And ORSC stands for Organization Relationship System Coaching. And it's a specific coaching where we actually work together as teams. And so this is a passion that I have. I coach doctors, physicians, because some of them and a lot of them have burnout. I'm also managed to give some talks during the pandemic when people are all stressed out, just to help them. So hopefully you're going to enjoy this. This talk was directed to women. However, I feel that everybody will benefit from them. Why women? Actually, statistics have shown that working women in healthcare, they are the majority. This actually in Europe, and as you can see, they account for more than 78% of the workforce in Europe. And it's also the same here in UAE. This statistics was done for Emirati teachers, doctors, and nurses in Dubai between the year 2013 and 2015. As you can see, they are the majority, especially being in healthcare, teachers, and nurses. So you can imagine the stress that they will have as well. And I love Alexa when she mentioned happiness, because that's what it is. Happy employees are better, they are more productive, they are better leaders, they're more creative, and they work together better as a team. So we are looking for that happiness bit. And you know, happiness can differ from one person to another. Satisfaction differs from one person to another because we prioritize different things. Okay, why I'm bringing stress back? Because there are health risks associated with stress. Stress is the biggest killer. I'm sure you've heard that, and it is actually a fact. We need to take care of our health, and knowing that stress can cause many things like high blood pressure, diabetes, obesity, and we will not live long if we are stressed. So where's Dr. Aisha? I want to live 100, inshallah, we all do, but with stress, that will reduce our chance. So no stress, please. All right, so what are the common causes of work-related stress? And I'm sure you've seen when we're talking about burnout, And maybe women suffer from this a lot because we have the obligation being mothers. I'm a mother, I have 3 kids, being working, and then we need to take care of the husband. You all need your wives to take care of you, and you enjoy that, you want that time with them. And so there's so many things going on. We need to think about our finance, there's inflation, there is so much commitment. So it's really actually difficult to exclude that during work. So what we should do then? All right, what is your therapy? I want to ask you, do you have any therapy plans? So in this picture, this is me holding a medal. I'm a runner. I joined many runs, more than 40 runs in the last 2 years. And I enjoy the fun of it. I enjoy the community of running. And this is one of the runs that's actually supporting organ donation. It's called Hayat. It happened in Abu Dhabi last year. So actually it makes me fulfill 2 elements together. Running is therapy for me. Definitely I'm taking care of myself, and I like running in races because it actually promote wellness, because I'm in a public health era, and I like to promote a healthy lifestyle. And also those that have charity or have an element, and it actually is like volunteering actually. So I enjoy that. And you know what? Since I started running back in 2015. And then I started joining races in 2019. At that time, there was not much Emirati ladies running in those races. And at my age, like that was difficult. And how are you doing it? And I started posting on social media and dedicating those medals and so on. And guess what? The number of ladies, Emirati ladies joining races had shooted up in the last 3 years, especially with the pandemic. Everybody wants to go out and see people. And, you know, they understand people who runs. How many of you tried running? Have you? Those who runs know it is therapy. Maybe it's the best it's the best than the psychiatrist actually. Because there is that happiness hormones, the oxytocin and adrenaline and so on. So it's my therapy. Others find yoga, others find painting. So actually I do find painting. This painting I have done, it's an oil paint. It took me 2 months to do it. And it was my therapy between work and my family. I had that 2-3 hours. I do it like every 2 days, so 2 to 3 hours per week around that, and I paint. And guess what? That's masterpiece that I have. I have more than 40 paintings. I joined international art exhibitions, and I love it, you know, because it's taking me away from the stresses in my life, and I wouldn't know that I can paint unless I experience. And I remember Dr. Aisha said that she tried so many things that she liked, she kept, things that she didn't like, she threw. So actually experimenting and trying new things, it takes you from that stress. It makes you discover new things about yourself, and you might find your passion there. Oh, the wheel of life. Everybody talked about the wheel of life. I'm talking about the wheel of life. But you know what? I like how Alexa said that she doesn't need 8, she needs 5. She knows what's her priority. So it's like a small pizza rather than an X large, right? And people differ. There are people who maybe want to try so many things. People who actually, not everyone has a family or kids or a husband, and they're fine with that. I mean, they have friends, they have travels. And others know family is very important, and extended family is very important. I have my mother, I have my kids, and maybe grandkids in the future. So you know what's best for you. You know your priority. You know what are the things that makes you happy and joyful. And when I do coaching, if you have got a good coach will never give you an advice. A good coach will have a good conversation with you where you actually come up with your own solutions, because we believe that every person is creative enough to find their own happiness, to discover what suits them most. So I don't give advice on divorce. I don't tell them, no, you get divorced, you stay married. I never do that because it's not my choice. It's not my life, it's theirs. But we have a conversation. What is most important for you? What will make you happy? What will make you joyful? What you can take out, what you can bring in. And those answers, you're going to answer them. So the wheel of life, you're going to create it. You know if you want a larger pizza or extra pizza. And as Dr. Aisha said, that life is, you know what the thing about balance, sorry, I'm going to take myself away from the mic. Have you seen a ballerina? I don't know. And have you seen how a ballerina, okay, that's good, yeah. So a ballerina is not standing on the toes. She's actually going there so fast. Her nail, her finger, her toe is going like that, so fast that you cannot see it. So balancing is actually moving. It's such a movement that is so fast and you cannot detect it. And that's what life is. So at one time in your life, when you were, for example, studying for your final undergraduate exam, your priority was passing that exam. Your priority was not family, was not traveling, was not friends. Your priority at that time was passing. And then years come back and you are married, you have kids. Your kids, when they're toddlers, are your priority. You cannot just miss a kid and go on call for long and so on. And you will choose a part-time job or maybe having a 1-year break out of work. So balance is actually moving in the direction of your priorities, which are changeable as you live. We change. We are all changeable creatures. We are changing and expanding and growing continuously. So that's normal, okay? So don't feel bad if your pie is not balanced because it's not supposed to be. It's supposed to be in the direction of what is priority for you. But it's good to reflect and see, is that the true priority? Because sometimes we get lost. We get lost in what is happiness for us. That loss happens from influence from outside, from social media, from peer pressure, from demands outside that are not related to what we actually believe in, what our values, what our beliefs. So if you feel lost, and we often do, right? I feel lost sometimes. Step back, take a deep breath, reflect on your life, put that wheel and check your priorities and see where I should clean and get my direction back. Okay, good. I saw this when I had a talk about happiness at work. And I saw this slide and thought, wow, I really like it. So I want to share it with you here. So some people, not only healthcare workers, but also those who are achievers, high achievers, who are very ambitious, and they're usually mid-career or beginning of the career, they would love to work longer. They are excited to work longer. They want that extra money. They want that extra bonus. They want to please their boss. So is that the true value, that working longer than what you need or what you are expected from you? So you might have that happiness. Oh, I'm here. I've done so many things. I'm excited. My boss loves me and everything. Maybe you're going to be dreaming of a future promotion. But you know what? There's no happiness there. There's nothing. You know why? Because I'll tell you, actually, your boss, if he sees you working a lot of hours, they will love that. They will make you work more. And guess what? They will not promote you because they need you. They need you to be under them. So they will not promote you. And you stay working forever and ever and ever. All right, what else? Okay, I got that bonus. I got that 1,000 dirhams or what equivalent in dollars. And yay, I'm richer now. Are you really richer? Are you paying for the tuition fee of the private teacher for your daughter? Are you feeling guilty and buying toys for kids because you're staying away for long? Yeah, probably you are. So that money is going out. So there's nothing there unless it is your choice. You want to stay at work because it gives you joy, it fulfills you. It's really something that meaningful for you, or you hate your husband and you don't want to see him, so you work extra hours. That's another issue. But you need to realize that the balance is important here. Your time, you own it. The one thing that does not come back is time. You can get your money back, you can get more kids, you can do so many things back, but not time. So time is the most valuable, and we have here a valuable time there because it's a life changer for us. Maybe this is the best day for you. It's a life changer for you. I believe in that. So little things that will make you happy at work. You can take a screenshot for this. If you want, you can also mention me on social media. I'll be happy. So 12 steps of happiness. These are things that you can practice at work that will help you feel better and happy and enjoy work more. One of them, say thank you. Thank you, thank you. I love saying thank you for everyone. And thank you for coming here. Thank you for bringing me here, Rola. So saying thank you, being grateful is really, really helpful. Do that. Thank your colleagues. Thank your employees. Thank your boss. You know, there's no problem in saying thank you. Do it more. Give. So giving by volunteering, by giving from your knowledge, by giving from your, some people they can give in different ways. Give from the something that you have and the skills and what makes you special. Give them that. Help each other. Eat well. There is a happiness recipe. I tell people, if you want to feel happy, so I'll give you this gift for you. If you're feeling really depressed and you want a happiness food, please don't go to McDonald's, okay? That will make you feel guilty and unhappy. Go get you a banana and 1 spoon of peanut butter and a yogurt, a little bit of honey, and maybe some nuts. This is a happiness recipe. It is healthy. It has a good carbs level, but it also have those, like say, amino acids and good fats, let's say. And the banana is amazing. All monkeys are happy, so it's good. And then exercise. Rola asked me, what is your secret? I have 3 kids. One of my kids is in college, alhamdulillah. And I told her the secret is I exercise every day. I run, not every day, at least 4 times a week, 5 kilo, 10 kilo, depends on how I feel. Exercise in the way that makes you comfortable. Listen to your body. By the way, listening to the body is the most important thing because you will know when you are tired, when you need to exercise, when you need a break, and when you need to sleep. So we need to learn to listen to our bodies. Take rest, sleep. The actual worst pandemic is we are all suffering from insomnia, and you know why. Social media, tell you. Everybody's on their phones, on the beds, and they don't sleep. Kids, adults, elderly, all same. Experience. I just came back last week from Al-Ula. I did the Al-Ula trail race run, which I actually traveled and experienced a new country. And it took me only 2 days. Al-Ula is in Saudi Arabia. They have so many beautiful things. Just Google it. And it's a culture, a heritage, a nature. It's amazing. So I had to say and talk to my friends about my experience, and I got excited to go to work just to tell them what I did in the weekend. So do something fun in the weekend, do something special, go outside your comfort zone. I did a scuba diving once, so do scuba diving if you want to. I mean, try to go out and experience. Experience actually add that level of excitement and happiness in your work and your life. Meditate. So we had the picture of yoga, and meditation is underestimated. It is so powerful. If you've seen people who meditate, you'll find them more relaxed, they're more focused, they're able to handle stress much better. So I do advise you all to try meditation. There's so many ways for beginners, for advanced. Just try and go there and experiment it. Hiking, Dr. Aisha said hiking. So hiking and feeling that rush of, you know, discovering and going to a tip of a mountain is such a fulfilling experience. And there's so much nice places in each country that you can try hiking in. Aim on, let's say, a target goal. Having a goal and working on that will really help you. Give it a smile. People who smile, they look happy, they feel happy. And you know what? It is contagious. So smile more. I have a workshop called The Magic of Tidying Up. It is from Marie Kondo. Who know Marie Kondo, the Japanese way of tidying. It helped me to discover myself and declutter. And I felt really much happy when I have less. Less is more, actually. And that applies also at your office. So you can clean your desk, you can tidy it up and make the to-do list. Talk to your colleague, celebrate your wins, be creative. These are little things that will help you enjoy your work more. And do some volunteer work. I love community work. I actually got awarded the Emirati Women Award for social work. So I do have a podcast channel. I've interviewed 33 physicians on different medical topics, including psychological ones. And I did it with zero budget. It was my thing, just interviewing them, no income, just I want to share that knowledge and values with people because I'm passionate about that. I also did the hiking. This is a picture for a group. We are hiking in Jabal Hafid, which is the second biggest mountain in UAE. You're all welcome to see it. It's in Al Ain. And these pictures of some of the doctors that I have interviewed. We talked about 8+8+8, which is happiness rule number 1. And that is 8 hours sleep, 8 hours work, and 8 hours for yourself. Anyone knows what 1 + 1 + 1 is? Do you want to give a guess? Try? You want to try? 1 hour of? Okay, 1 hour of exercise. We all agree on that. 1 hour of reading and 1 hour of actually 1 hour only of social media. And you know, that's the most difficult part, especially for bloggers, I know. But imagine, just take, I'm sure you've tried to take a break from social media and you feel alive again and you have so much time to do so many things. So try to minimize the use of social media. I'm a blogger myself and a social media influencer, so I have to post some things. However, put it on the thing that is valuable for you. You don't need, you know, TikTok, Instagram Reels, and so on. They just, you drag and you will lose time without noticing. So just try to limit it and be aware of it. This is a slide that I used when I gave the lecture for the healthcare staff. Sometimes we live in crisis. We have uncertain times. We don't know what to do. We are stressed out. So having a daily routine where actually you are having your own habit, you're exercising, meditating, and they're trying something new, the experience, talking to someone. You need to talk to someone. We are creatures that we love. Rola, she was talking to Alexa. Me, I talk to Aisha. You know, that kind of community. We are born to communicate and socialize and support each other. So don't take that. I know that sometimes they talk about in self-development that it's all about you and is you are enough to have your own happiness and no, you don't need anyone. No, we are a community. We need each other. We need that support. We need that support. It's okay. So when I have a me time, I paint, and these are some of the paintings as well. I experiment water paint, oil paint, everything, and it's always a joy. I love them. It's like my babies. So this is a video. I don't know if you can play that. Is it playing? I hope it comes with the sound. It's for women, so she can. How sound is not clear, but it's okay. Cheers. She's all that. You are. So that was in a Happy Women's Day video, but I thought it was fulfilling this time. So with that, I'd like to end my presentation, and I hope I kind of wrapped everything together. And if you have any questions, I'm here for you. Thank you.
Thank you so much, Dr. Lamis. And really, we brought it all together. And I truly enjoyed your tips. And it's a nice reminder, even though that we had some repetition, but this is the good repetition. So keep it in mind. And I would like to thank you all for staying that long. We're going to have dinner now together. I'd like to thank Dr. Mohammed Al-Bashir, for the president of the conference, and for having this workshop bundled with this wonderful conference. We're looking for a wonderful 2 days of breast cancer conference, and mainly it's multidisciplinary. However, leadership for women is very important. I'd like to thank MCO. Thank you, Joseph, for all your help and for all the recordings. Thanks for the wonderful speakers coming all the way internationally, even for 2 days to be with us means a lot to us. And I really appreciate that you taking time away from your families, from your work, to be with us to make the world better for women and for everybody related to women. And I'd like to thank my colleagues who are on the line with us, the virtual speakers, the virtual attendees, and the on-site attendees. Have a good night, and we'll see you at the conference tomorrow. Don't go anywhere, Lamis.